Hawaii?
Yeah, we are.
Okay. I like Maui. We did a massage convention there one year. Yeah, it was in '93, the same year that we had our 50th anniversary here. That's when we used to have a constant dancing back.
Play on it. Oh, that's it. So should you reboot the page?
It did.
Oh, there it is, right? Yeah, okay, cool. Beautiful. Nice.
It was a last minute thought.
Yeah.
Sorry about that. Hi. Doing medial thigh pain today.
Oh, it's almost.
Oh, yeah.
Medial thigh. Do we have thighs?
We have thighs.
We
Yeah.
have thighs. Oh, yeah, you worked on mine in the last 2 weeks. We have
Yeah,
thighs.
we have thighs.
Okay. We have thighs.
Thigh is the upper leg.
We have all
Leg
thighs.
is actually
The lower
the
leg.
lower leg.
Yeah.
Ah.
Yeah. Well, you know.
You've got hips, then your thighs, then your knees, then your legs, then your ankles, then your feet.
The hip bone's connected
To
to
the thigh bone,
thigh bone's connected to the
knee bone,
knee bone's connected to the
shin bone,
shin bone connected to
ankle bone,
ankle bone connected to the
foot bones,
foot bone connected to the
toe
bone.
bones.
For the patients that have,
Okay. I'm going to be upside down for just a minute here. Here I am upside down. How's everybody doing? Has anybody tried a few compaction corrections? Have you been making sure you work on the origins and the insertions of the muscles, not just the trigger points that are in the bellies? Remember, there are three main areas you want to work on in the muscle. There's the neuromuscular junction, where you find the main trigger points. Then there are the Golgi tendon organs that are at the attachment points. And then there's the rest of the muscle, which just may have contractile tissue that's too taut. And so you just want to get all different myotactic units working, and that's full range of motion. Full range of motion is every myotactic unit lengthening and shortening completely. And so we were testing range of motion, we're testing strength lately, and then we've been treating on the short, on the long, on the stretch, and we've been treating the origins and insertions, as well as the belly and all the other areas of the muscle that we feel any taut bands.
frequently we're addressing the nerve.
And the nerve roots,
Yeah,
that's
yeah,
right.
so-
This was the third spot. The third spot was the nerve roots, all the intrinsic spinal muscles that control the nerve supply to that muscle.
So today we're doing medial thigh pains, which is 24. And so that let's take a look at what muscles are in 24. The most likely muscle to cause trigger points and pain in the medial thigh would be the pectineus.
I think pectineus, isn't that what they put in my jelly?
Yeah, the
Oh, no, it's
pectineus.
pectin,
Yeah. Then we got the vastus medialis, is one of your quad muscles.
Oh,
on
yeah.
the inside of the knee.
Yeah,
It goes to the
medials, right.
The gracilis and the inside of the thigh there. The adductor magnus takes up a lot of the space there. and the sartorius. Okay.
So this looks like to be one of those things. Medial thigh pain is often caused by muscles in the medial thigh.
Yes, it is.
Right. Now that's not that common with a lot of these we've been seeing, but this one.
This one is.
Oh, neat. All right.
So this is good. This it does, and also now I just want to mention that next time. This time.
Next time, yes.
Oh.
Next time's so cool. All right.
Okay. Next time. This time is also medial knee pain, but the next two times we're going to do the next two classes broadcasts. We're going to be protocol 25, 26, and 28. So you can download those. So here's 25, lateral knee pain. 26, anterior knee pain. 28, anterior medial knee pain.
And we'll be doing 27.
And then
right?
the 27 we'll be doing the following week.
Yeah. Oh, yeah.
And
right.
that'll be here. Posterior knee pain. It's quite a few different muscles in the back: the gastrocnemius, the biceps femoris, popliteus, semitendinosus, semimembranosus, soleus, and plantaris.
Yeah, that one has enough muscles to get its own week.
Yeah, it's got its own week. It's got its own week. Okay. So that's coming up. So it's the amazing knee pain relief program.
Oh, that's it. After you do that, if you can do those 4 protocols.
That's right.
And you know that you've gotten your perpetuating factors taken care of, because knees need perpetuating factors.
Right.
Then you can fix almost any knee condition.
It's going to be great.
Yeah,
It's going to be great.
Before they're completely destroyed, I guess. But in most cases, even really,
What if we could keep our joints our whole life?
Yeah, why not?
All the way.
Why not?
Maybe we could.
Yeah.
Okay, so what if they got a lot of compression and decompression, and a lot of good blood supply and drainage, and got the right amount of use? We might be able to keep them.
Oh, here's an interesting fact.
Yeah.
90% of the protection of a joint is done by muscles. So there are ligaments holding joints together and tendons.
But the muscles
but the muscles are 90%.
See?
Yeah.
90%.
90% is muscles.
That's great, great. Okay, so we have some guests here today.
All
so
right.
if we come over here, stand up. So this is Nora, and she's here. We're gonna take a look at her medial thigh.
Ah, okay.
Tell us anything about about trigger point work, or anything about yourself.
I love that I can fix myself.
That's right. That's what's one she's really excited about.
Yeah, I mean, it's great to come and get fixed, but it's even greater to learn how to fix yourself.
Yeah.
See, the word of the day.
Been great.
Yeah.
The word of the day. Yeah, stand up, Kirk.
Hi.
So what did you notice? How far are we along?
About just over halfway.
Yeah, halfway.
Yeah.
It's the first class and the second half.
Yeah.
Yeah, so is that amazing?
Oh, we're on the downhill slide.
So you know what we're doing? No, we're not. We're on the uphill. We're going for it. I'm getting so excited now.
Oh, I see. We got momentum.
I've got momentum now. We're gonna fix every pain problem in the entire body.
Oh,
What do you think of that?
I think it's good.
That's gonna be out there for
Why not?
everybody.
Yeah.
It'll make the winter go fast.
Yeah, exactly. We're going to make
We'll
this
have
winter
something-
go fast.
We'll have something to do in the winter
Yeah.
while we hibernate.
Yeah.
So how you been doing with your trigger point work?
Good. I've come a long way. I've got more to go, but I'm learning a lot too, and able to help myself a lot. I'm really happy with it.
And you're bringing a little bit to your community. He's
Yeah,
an
just
advocate.
helping a few
He's
friends
a self-care
Here and there,
advocate.
showing them what to do for self-care
Nice.
And he
and
is.
help them a little bit.
Yeah.
Thank you, Kirk.
Yeah,
Hi.
great. And so this is a massage therapist, Camille.
Yeah.
She's been having a massage therapy practice for a while.
Oh, wow.
A few decades.
And
Yeah.
we've been working on a few interesting things with her.
Yes.
Yeah, so we've been excited about the things we've been working on.
Yeah,
You
we
got to
finally
those
got
nerve
down.
roots on me the last
Yeah,
2
we
weeks.
did.
That was good.
Ooh, ooh, ooh.
Yeah.
That was good. That was
Something
good.
else.
That was good.
stuff. Yeah.
So we're doing a few things with you over time.
Helping me come along.
Mhm.
Yeah,
Yes.
great. How did things go after your treatment last week?
I definitely feel better after the last 2 treatments. Yes.
Great.
Yes.
All
So
right,
we worked on a lot of great underlying and important factors. Yeah.
Yeah.
Yes,
Yes.
definitely.
Super. And Stephanie, she's here.
Come on,
So Stephanie's here also. She's my apprentice.
She's the wizard behind the curtain. Even if you don't see her, she's the one making it all happen behind the scenes.
Yeah, she's working. Okay, so we've got a few people here today.
Okay.
Yeah. And here's our muscles.
Let's take a look at them because some
Here's
of
our
these are just
protocol.
not familiar muscles. I don't.
Yeah, they're
pectin
yeah.
muscle. What's that?
The pectin, yeah.
Sartorial muscle.
Okay, so here we've got the muscles. This is protocol 24. So this is the. So if you see that's the section that would be hurting, and this is all the areas and pictures on which area and where you're going to treat. But we're going to do it together with you.
Is that
Then
the
I
one you
have.
printed off of
Yes,
our
I did.
website?
This is the one.
Myofascial.com. You
we
just
did.
get this, yeah.
Yeah, we
it's
just
the same
got
one.
it. It's the same
Yeah.
one.
All right, you guys.
You could have it in
can all
black and
this,
white
yeah.
or color.
All right. Nice.
But it's prettier in color. I think you should print it in color.
Yeah.
Yeah. And then here's how to treat everything with pictures. So we're going to do the same things that are in the pictures today, as well as do some other things.
Oh, yeah.
Okay? And then this is how you stretch everything. And a lot of times people might ask, well, how many times should you stretch throughout the day?
Yeah. How many?
Well, what if you knew the range of motion test that you're trying to accomplish, you know? And you notice that when you treated it a little bit and stretched a little bit, it got better, but then you're encouraged and you wanted to do it a lot more.
Right.
You could.
Yeah.
Or what if you're really busy and you can only get a little in?
Well,
That's good too.
That's still good. Yeah.
Yeah, that's both good. Both are good. So you could just decide yourself.
Yeah.
But, you know, if you're not getting the results you want, you could do more.
Yeah.
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 So
The
we can...
things want to heal, you know. So any kind of input you give is you'll take it and use it.
So this is where we're micro stretching, right where the elbow is pressing,
Yeah, that's the compression.
and we're using the compression. And
So
this
compression
where,
is kind of a stretch in effect.
in fact, it's stretching at the cellular level, at the right in the taut band, right at the cells there. It's like stretching those cells in the fascia.
Right.
Then when we do these stretches, now all the tissue is available for stretching.
Right.
And when we do strengthening, all the tissue is available for strengthening.
Right. So what
Yeah.
you're saying is, if we just did these stretches like typical
Yep.
training is, typical physical
Then
therapy.
likely the dysfunctional tissue would still be dysfunctional, and
Right.
it might still be causing the referred pain.
Yeah. So the
What if
part
you did the
causing the pain
strengthening?
isn't going to stretch when you're
What if
doing
you
those.
strengthen these muscles?
Well, then only the parts that aren't hurting are going to work.
Yes, correct.
So you're
yeah.
still not fixing the part that
right.
hurts.
So we're going to fix the part, then do strengthening and stretching.
So
the
essentially,
idea.
it is utterly insane to think that you're going to fix muscle problems without treating the micro stretch that's needed.
Right.
That's it.
And so when we're doing that, we're pushing out those painful sensitizing
Oh, and
chemicals,
that too.
and then the nerve can communicate better to the muscle,
Yeah.
and then we're going to then have full function and full use of the whole muscle for that reason as well.
If they stay contracted too long, those little units, it's like the central nervous system says, "You're dead to me. You're dead to me,
You're
son,"
dead to me.
and it doesn't communicate with it anymore. You know,
Well,
you got to get those back.
was talking about the vastus medialis. She said this muscle, and it happens with a lot of muscles, but she happened to mention it with this one. That a lot of times the first phase is it's excruciatingly painful when it hurts at the attachments and it causes referred pain. And of course, for this muscle, the one she's talking about causes referred pain here, and the medial thigh. That's the vastus medialis.
It hurts at the
comes down
attachments?
on it could hurt the attachments, but this is the referred pain pattern right
Oh, yeah.
here. And it goes all the way down to here, but it could hurt really bad at the attachments and then inhibit you from using the muscle. And then, further turning it off.
Right.
But she was saying that what happens a lot, she didn't say why, but a lot of times it hurts at first and causes this referred pain and causes a tendinitis, but then after a while, it just turns off. And then it doesn't work, and it's just completely turned off, and that's what happens a lot to a lot of the longer muscles. But I think it happens to lots of the muscles. Yeah.
And
So-
that, of course, does that affect the patella too when it does
Yeah.
that?
Well, this is attached to the patella, and it's attached to the patella tendon, so it's actually attaching right here. So this is where the vastus medialis comes and attaches. You could say right here. So that's it. It attaches up there. So that's its attachment here. And that's its attachment here.
So patella problems, you definitely have to look at this muscle.
Yes.
Right?
Oh, yes. But look at this. It's the biggest cause of buckling knee syndrome or
Yeah.
trick knee, and Travell called it the buckling knee muscle,
Yeah,
and she
buckling.
also called it the quitter because it just quits.
It's like when a football
Just-
player does that move, they're running, and then they cut real fast.
Yes.
And they just, they dodge immediately to the right or left, and then the knee buckles, right?
Yes.
That's where
This
it
goes
just
so
buckles, boom.
buckles and also just collapses.
Yeah, collapses, exactly.
Collapses. Well, oh, and then it feels like, oh my gosh, I'm gonna fall downstairs. I
Yeah.
won't even know what I'm doing.
Yeah.
I won't be able to stand. It's very disturbing.
Yeah.
Just all of a sudden your leg buckles.
Yeah.
Okay,
yeah.
but it could just be from minor trigger points in this buckling knee muscle here. here, the vastus medialis. Okay,
Cool.
so now what's the most likely muscle to cause trigger points and pain in the medial thigh? The most likely one is pectineus.
Right.
Okay,
The fruit muscle.
the fruit muscle, and it's got L1, L2, and L3.
Okay.
The vastus medialis is the second most likely. That's L4.
That's the quitter buckling knee
That's
muscle?
the quitter. That's the quitter. Okay, the muscle. Okay.
If you have a sports athlete, you definitely want to make sure and evaluate that one.
You don't want that quitter going on.
No.
And then the gracilis, okay, that's L2 to L4. That's your nerve roots there, the adductor magnus. But in addition to the L2 to L4, it's also L5 and in S1 in certain section of it.
Okay.
And then also the sartorius. Now I'll have to show us. There's no test on there for sartorius, so I was going to give a special test for that. Okay.
Yeah. It's the lap muscle. It's the one that pulls you up into a lap.
Yeah, it gives you a little lap
Yeah,
here like that.
exactly
Yeah,
like
but
that.
it also gives you a little place to sew. So you can go like this and then you can sew.
Because it goes from right
Sartorial
here,
splendor, yeah.
medial knee, right up
Yep,
there.
here, right here.
Yeah, and it wraps around. So.
Let's take a look at
Yeah,
that
let's take
one.
a look at these ones.
Let's look at those muscles. So let's
Okay.
look at the most likely one first.
Pectineus muscle.
Yeah, let's look at the pectineus first. Here it
Isn't
is.
that like the fourth adductor or something?
It is the fourth adductor. So her nickname was for the fourth adductor.
Yeah.
And it's attached right here to the pubis and the ramus there. And then it comes over here and attaches to the femur. And it causes pain right in that area.
Mm-hmm.
And it brings the femur towards the pelvis there, or the pelvis towards the femur. And it causes pretty wicked pain there.
Uh-huh.
And of course, we want to look at L2 to L4 for that. So it's right for pain pattern. Let's look at number 2, which is the vastus medialis. And that one causes this pain right here. It's L4. And it attaches right there, just below by the lesser trochanter, and then over here onto the tibia.
Or it
And
gives
then-
you wicked side of the knee.
Oh,
pain
it
there.
does, right there.
The lower tier
Really bad inside the knee pain. So it's a causes a really bad inside the knee pain. And I was going to mention that especially because that's our next 2 classes coming up.
Is referred pain tender to the touch? Like if they were to
It
touch the knee?
can.
Right?
It can be. Oh, it could be so. It could be so like you could go like this. It could be like
it's
this.
like, ooh, yeah.
Like that, and it could be referred from the trigger points in that muscle.
Wow.
And as soon as we relieve it, then all of a sudden you could just go like this. You go like it doesn't even hurt.
Yeah.
It doesn't. Why doesn't it even hurt?
You could listen to funny jokes again.
Okay, so that's so this is it. Now let's do the gracilis. That's number 3, and let's look at the referred pain for the gracilis. Oh, I didn't put it in the right place. That one.
We'll get it, we'll get it.
It fell off. I didn't put it back on. Here it is. Here, I'll put that over here. So here's the gracilis. And you can see that it attaches right here on the tibia, and that along with the sartorius and the semitendinosus make the pes anserinus there. So that's where the duck's foot is.
Oh, yeah.
Then it attaches here to the ischial ramus right there in the pubis. So this muscle, though, it's very interesting. It causes this referred pain right here, okay? But I find that because it pulls right here on the pelvic floor, it can cause some very wicked pelvic floor and urethra pain and dysfunction.
Wow.
So it causes the tendinitis, actually pulls hard. It causes some very bad pelvic floor dysfunction. And it makes you feel like you have a bladder infection.
Oh, really?
Yeah. So you could decide, you can make your appointment with the doctor, or you can get, say you can get your end back, but they could treat it first and go, it went away in one treatment.
Yeah, yeah.
I guess I don't need it.
Yeah, you could do that. what does this muscle do? I don't.
Oh,
it's
so it works along with the adductors, but
So
it crosses 2 joints. So
Crosses two joints?
it crosses 2 joints. So it's kind of like the sartorius. It crosses 2 joints, and it's an adductor.
so it brings the leg in,
Yeah.
and kind of like the sartorius because it crosses the knee. It kind of helps make that lap.
Yeah. So that's our. Let's look at number 4. This is number 4. This is our adductor magnus, and you see it's a big muscle here. It attaches here onto the ischial tuberosity here, and then down over here to the this part of the femur.
Again, it doesn't cross the knee. Then.
No, this one doesn't. No,
None of the actors. The sartorius and the
sartorius does. Yeah,
and the gracilis does.
Yes,
Wow.
yeah,
Okay.
yeah,
Cool.
yeah.
And the vastus medialis, of course, does.
Okay, and then that's number 4, and that's she calls that the obvious problem maker, and that it's it has L2 to L4, and we're gonna do these range of motion tests for it here. And the adductor magnus has also this L5 to S1. It also gets some of these fibers that go up and down also get sciatic nerve innervation.
What's its referred pain like?
Oh, let's look at that. Yeah, this referred pain, this very interesting referred pain. It goes up into the pelvis here,
Yeah.
and it can activate organ problems. It could cause all kinds of pelvic floor dysfunction. So it could be causing urinary tract issues.
Mm-hmm.
So this would be the adductor magnus can cause pretty painful. Plus it has this pain going up and down.
Wow, so medial thigh pain, really you're working on muscles mostly in the medial thigh again.
That's it,
so
yeah. But in addition to causing medial thigh pain, it causes some very bad pelvic floor dysfunction.
Right,
Yeah.
cool.
Yeah. So we'll want to check. I love to check the strength and the range of motion and the stretch for this one. Yeah.
Perfect.
Yeah.
Okay.
So that's it.
good.
So we got one more. Only one more.
One more?
Let's see, we did. Well, did we? Oh, wait, sartorius. Here it is. So this is sartorius. No. That's gracilis.
Yes,
So sartorius. So one more.
Longest muscle in the body.
That's it. The longest one.
Crosses the hip and
Yeah.
the
Yes,
knee.
it does. It does.
And when you pull it together, it draws the knee up and the hip up, so it makes a lap. Like when you bring one leg over the other like this, makes that lap. That's what the sartorius does.
Oh, it's right here. Here's the pain. So
Okay.
the upper part of it causes the pain high. The middle part causes it in the middle, and the lower
Look at
part
that,
causes here the
straightforward
lower.
this week.
Oh yeah, very straightforward. Attaches here with the other two, the sartorius, attaches with the gracilis and the semitendinosus right here to make like it looks like a duck's foot tendon. And you can see it attaches at the superior iliac spine and then down here onto the tibia.
Yeah, and that's a point to work too. I mean, right where that, because all
Yes.
three muscles are certain, that's a great attachment point
Yeah,
to rub.
We can go in there and take a look at
Yes.
that. And this is the one also that can cause that nerve compression called,
Neuralgia paresthetica.
and then so it's entrapping of the lateral cutaneous femoral nerve.
Which,
So in the next page has so it makes it numb all on the outside of the leg here.
oh yeah.
Yeah. So I actually.
What else makes it really numb is sometimes very tight underwear.
Uh-huh.
Very tight underwear can cause this nerve problem too.
So here, you guys, I brought these out for you guys to look at. So you could look at page 230. So this is so in addition to it, this is see it sometimes it goes through the sartorius right there,
Yeah.
and then comes out here and causes numbness out here. But sometimes it gets compressed by the psoas right here.
Oh yeah.
So when we release the psoas here, it often it releases it also. It could be released by treating the nerve roots. Yeah, might be.
Yeah.
But this particular thing would be most likely.
And
as it comes out
sometimes you
here.
just fix a Morton's foot and all these muscles relax and release and lots of things go away without hardly having to do any work.
It could happen.
Could happen.
It can happen that way. Yes. Okay, so we're going to do the first muscle first. Let's do pectineus.
Beautiful.
So let's do the range of motion of pectineus.
All right, what is it? 43, right?
Yep. So it's the fourth adductor, and we'll do the range of motion test for 43. Yep. Let's put this over here.
So there's two actually in this test. There's the put the heel on the inner thigh and let it fall down to the table, and then there's the pulling it out, kind of like a range of motion test, abducting the leg as far as possible and feeling the end feel. And about 90 degrees abduction is pretty good, sometimes even more. As you lift the leg a little and rotate the heel out, you can even get more than 90, but so that's, you can test that, and it should be both equal on both sides. It's a nice soft end feel. Remember, the end feel should go smoothly to the end, and then there should be a little springy at the end. It shouldn't be resistance and tightness, and getting to the end is hard, and there shouldn't be a taut, resistant end feel. Right?
Right. Okay, so let's take a look at that measurement.
Great.
Could we look at you? Yes?
Okay. What do you need?
We're going to measure your range of motion.
Lying face up on the table?
Yeah.
Shoes on? Shoes on? Doesn't matter?
Doesn't matter.
Okay.
I'm going to take this off. Okay, so we're going to measure So everyone at home, you could get a partner. It'd
Yep.
be good if you could measure them. And there's a couple different ways we like to measure. One way is we like to come like this and kind of measure like that and hold that hip down. Then we measure from the lateral patella to the table. So you can, so that's good. Another way we like to do it is come up like this, and then we're seeing if we can get so scoot that way a little bit, and we can see if we can get the leg to the table. So here,
so you
very
can see
good.
this isn't too bad.
Yeah, very
Not
good.
bad at all.
So that's minus 3 inches. Okay. And then sometimes I like to measure like this. And then it would be a little bit different. So this is the way I like to do it. And then that would be minus 4.5 inches that way. Okay, let's try it on the other side. So remember, minus 3 on this side. Okay. So let's do it this way on this one. And we're gonna come this way and then come to about there. Oh, we have to get you closer to we can't measure. So we have to get you this way.
And you can
Okay.
see as it goes down, you can already almost tell that there's a nice soft end feel. It's not real
Yeah, it's very
restricted.
nice, very nice, yeah. So this side here is a little better, 2.5 inches. So
Great.
this one's a little tighter, yeah. So this one here is a little looser. Okay. And let's check the other way. This is the Sharon way. We come to the Sharon.
The Sharon, yeah.
Okay. So it's 4.5.
That's
on the other-
different that way,
Yeah,
too.
here it's 5.25. So it's getting a little different something.
All right.
Okay, all right. So that's good. So that's a nice little test. So that we can see. And then the other one we want to do is we're going to do this one. We're going to lay, and we're going to check you this way. We come that way. We're going to come out. Okay, so she was scared, but I was stopping right there because I could feel it.
Yeah,
So
you can feel
right
that
where she
end
was
feel right there.
just right where she was saying that.
Yeah.
I could feel it, yeah. So you could measure with your measuring tape. If you had a table right here, you could measure over here. So it's about 16 inches. And that would be one way. We also use the goniometer, and we look at the angle.
Yeah,
That would be nice too. Stephanie, you
Or,
could get me
or another way is you could
get me a goniometer for the other side.
you could also look at it this way, where you come out like this, and you can see how far it goes, as in that hip adduction to abduction, and that's you could look at that for 90 degrees, and that's very restricted there too as well.
Yeah, that's nice. Let's look at that. Okay, so we're going to look at again the adductor, and it comes out to about here. Yeah, she doesn't want it to come out. Okay, let's see how far here.
But that's why it's good to have more than one test, because she did really well in the others, but this
18
one's
inches there.
this one's revealing a different
16,
aspect of
18,
the adductors there.
So that's your adductor, nice adductor test. Okay. So just taking it out to the side and looking how far it goes is just even good enough. Also just seeing how far that goes. So those are all good.
Should we
So
do the
then-
strength test right away?
Oh yeah, let's try the strength
Yeah,
test.
and
Let's see how strong it is. Yeah, we're gonna try the strength, see how strong the adductors are.
So you brace one leg, and then the opposite leg, I'm going to push this way. I want you to push inward against me. Okay, you push first. She pushes, then I add. Okay, and it not only that,
weak.
but it's also very weak.
It's really weak,
Okay,
so
try
it could
again.
mean
So
that
push
there's trigger
in
points in it.
And push hard as you can. No, it's very weak. Okay.
Very weak. So we want to
let's try
check
the
that
other
again
side.
after we treat her and see if it's strong. Okay.
Exactly. So now I'm going to brace this side, and on this side I'm going to push out. So push in against my hand, in, and then I add 1, 2. No, so not even 2 increments of increased pressure, and it weakens. So adductors are weak on both sides.
Well, it's weak.
Yeah.
Yeah, weak. So it has a little bit better range of motion, but it's weak. You know.
So
yeah.
trigger points could cause weakness.
And some of the restriction on range of motion.
Origin insertion points could cause.
Now, I was going to
and
show.
nerve issues, nerve interference.
I would like to show another test.
Yes,
okay?
please. Yep.
So if you could go ahead. This is so I use this test a lot while I'm treating. So this is a great way to test. So if I can have you lay sideways and face that way, I'll give you a little pillow for your head. Okay, so we're gonna have this knee forward, and we're gonna have this one backward. Then I'd like to see if it actively and passively can move and work.
Oh yeah, I remember.
So I like to get my elbow in the muscle fibers, and then I like to see if they're working. So I get in there, and I'm looking around to see if they're working. And I see this magnet isn't working right here. I feel that right there. What does it feel like to you?
Painful.
Feels painful, yeah. So we're looking for the painful spots.
Again,
and
can you
also,
describe what working means to you?
oh, look, oh. Hey, you guys.
That
Okay,
hurts.
so it's not contracting. So like if I'm moving it, it shouldn't just go like a board, you know, and get really tight. It should just like softly move, you know.
So you're feeling each of
So-
the spots softly moving in
Or not softly moving.
Ah,
Yeah.
gotcha.
So what if I start to move it? It just goes board like it won't move. Okay.
Or if it's stiff and won't move or something.
Yeah, it won't move like at all. So I'd say it was mostly moving, and we
Mhm.
had a few areas that weren't moving here in the adductor magnus.
Cool.
So any rate, so why don't we treat them on the
Yeah.
side? This is a really good position to treat in. Are you pretty comfortable?
Mhm.
So a lot of times we might put a little bit of heat on it, along with what we're doing. So maybe if you could.
Do you
turn
think if
on
we
my-
treat the adductor, we might affect some of the other range of motion tests for the other muscles?
We might.
Do you want to do those first, or do you want to treat them first? Whichever you
Well,
like.
okay.
Whatever you
Well,
do.
we could definitely do all the range of motion tests first,
Sure, we can.
like we've done like before.
Because I think that 43 actually is on almost every muscle, isn't it?
Yes.
That test we just did.
Yes.
Yeah, it's the same test.
Yes, that's right. Okay, so what other ones we were supposed to do? The other range of we'll just do them.
So,
we
so
did-
for example,
we did
vastus
43.
medialis was 43, gracilis was 43, adductor magnus was 43. So really the only other test we have is for the vastus medialis we have 33, and for the adductor magnus we have 36 and 37. And then you were going to show us yours for the sartorius.
Right. Okay, so
We really have 3 more to do.
3 more. Okay.
Okay,
So let's look at 33.
33 is for the vastus medialis. Okay. Heel to buttock. This is measuring its effect at the knee more. The remember 43 we just did would affect its effect at the hip, and then
This would be more for vastus medialis, especially if we move it a little bit to the lateral when we're doing it.
Exactly.
So that
So
would be
that's
for
for
our
the
vastus.
knee.
Yeah, so that's our vastus medialis, and it goes a lot to the knee
yeah.
and to the patella, so it's a knee, so it's a good one.
Yeah.
And so the next one we want to do is a 34, which is knee to the armpit test. Okay, and that's going to be also for well, it's more for the hamstrings and the
It's
gluteus.
36 and 37.
Oh, no wonder.
yeah,
Okay,
yeah.
36. Okay, so the standing toe touch at 37 as the leg lift. Okay, and so those would be affecting our muscles that we're working on, the adductor magnus.
There's a little bit of adductor involved in
And this gets
in-
your adductor magnus. Yeah, so this does your adductor magnus. Yeah.
So, but those are mainly for other muscles. We use those more for other muscles. But
We
yeah,
do
a little bit
hamstrings.
of adductor there.
Yes, but part of the adductor magnus acts
Yeah.
like a hamstring.
Yeah, and if you do this one, you're kind of getting that anyway. If you do this
We
one,
did, we
you're
did.
really getting it. Okay,
did.
so
We did
so that's
good.
it. I think that's the main range of motion test is really that 43, feeling for the adduction of the leg.
Yeah.
Abduction of the leg.
And so we're
Ready for treatment, or you want to do those? Or?
well, we could do. Yes, thank you. Yeah. So we could do treatment. Yeah.
Yeah.
We could try it.
Did you want how about the sartorius? You said you were going to show us a test.
Oh yeah, nice
the
test for
sartorius.
that. Let's do that first.
Yeah.
Okay, so here's the sartorius test. So so what does the sartorius do?
Makes
So
this lap.
It does. So it goes this way,
Yeah,
which she's
exactly.
able to do pretty well. But it could be nice if you go just a hair better. But this is very good. It's nice if I can get it up to about here.
Oh, okay.
Without but still very good. And then if you can get it this way, but just a little further. So here, okay, you can feel that. You're a little tentative about that. She can feel. So I would like it to get to maybe about 45 degrees this
Yeah.
way here. So we get a little bit more. I can feel it. It's a little stiff there. So I know a lot of times a sartorius is dysfunctional. It might only go this far in, maybe that far out. You know?
And the test for the sartorius is very similar. The muscle strength
Yeah, you
test
do the
is
strength test
similar.
would be the same. Well, I would do it this way.
You do.
That shows how you would do it.
Yeah, yeah.
So go, push your ankle inward, and I'd be looking how strong it is.
Yes,
And then I'd
exactly.
take it out this way, and then look at how strong. Okay, and then again I'd look here, push towards me, and I look how strong, and relax, and push. So you give me the strength test.
And then for the entire muscle, at once we go ahead and put that in the same position like this, and then I'm pulling just down toward me equal amounts with both hands. So you push up at the ankle and knee toward that wall, push together, and then I'm pulling toward me, and they go down. Okay.
So
So
yeah.
that's weak on that side.
Okay, let's try it on this side.
Okay, same thing. Push up with both the ankle and the knee. Push up, and then I'm going to add, and they both go down that side. Okay.
Okay, so
Yeah.
do you want to do the quad test?
Yeah, the
Why don't you
vastus
do
medialis.
Yes, let's do the vastus medialis.
You bring one knee for stability, and then you bring this up knee to 90. Put your hand right here, and for the medialis, we turn the knee outward a little bit, and then push straight up toward the ceiling. Push up, and then I push down. 1, 2, 3, 4.
That's strong.
Okay, strong.
That's strong.
Okay,
That was strong.
that was a good one.
Something's
Something's
She
working.
did it. She
Yay.
did it. She did it.
And again, turn out to
A
get
little
more
bit
of the
for the
medial.
medial part.
Okay. It doesn't like to turn out though a lot. It can
No,
feel
it doesn't.
that.
It doesn't want to. Yeah.
And push up toward the ceiling, and then I add 1, 2, 3, 4. Okay, good. So those were
Those
strong.
were good. Those were good.
What else?
Okay, so we wanted to test the heel to the seat test. So
Yeah.
that was the range of motion test.
Oh
You
yeah,
want to do that for
I'll
us?
do that. Sure. The heel.
Heel to the seat,
Heel to the seat.
and she just about passes that.
Yeah, she
I'd
really
say
pretty
that's
much passed that.
half an inch there.
With the knee turned out a little bit, right?
That'd be fine.
Okay.
Well,
Or is it knee turned in? For
In.
In
Yeah.
for the knee. Yeah. Well, she does both pretty well.
yeah, about a half
About
inch.
that,
Yeah.
yeah.
Okay.
The other side
Okay,
here.
the other side.
This would be again more for the vastus medialis effect on the knee. So like
Yep.
that.
There you
like
go.
that.
Yep. Mm-hmm.
Yeah.
Mm-hmm. Pretty good on that part.
Yeah.
Mhm.
Okay.
Okay, so now shall we treat that?
The only other one was the gracilis
Oh, we
and the
didn't do the
pectineus.
gracilis. Okay.
The only difference in the muscle test is you have the patient turn in.
Okay.
So the adductors were straight like this.
Right.
Pectineus, you have them turn in and push in toward the other side, and I push up at a 20 to 30 degree angle. Push in
Okay.
with my hand, and then I push up. 1, 2, 3, 4. Okay, so the pectineus and gracilis seem to be better than the adductors. So you're pushing down and in, and I'm pushing up and out. Push in. 1, 2, 3. Okay. But this one just push straight laterals for the adductors. Push into my hand. 1, 2,
That's
3.
weak. See-
Okay.
See how that is? Yeah.
So you differentiate. When she turns her foot in, the more inner pectineus and the gracilis, they grab, but the
Okay.
adductors not at all.
Okay, so next let's look at an underlying perpetuating factor. Let's have you stand up, and then we'll go to treatment.
Oh yeah,
Okay.
perfect. Oh yeah, that's a great idea.
Okay, let's have you take off your shirt.
Because you always got to think, how good is it if your treatment doesn't last? Well, not as good. So you want to make sure the
That's right.
perpetuating
Understood.
factors are
That's
taken care
understood.
of. Yeah.
Okay, so here we want to look at. So for some of the muscles, we want to look at the L's.
Oh yeah, we're
And-
looking a lot at the L's and
L.
a little bit the S for the part of the adductor. You said right?
Right.
Okay.
So here the S's are pretty good, but maybe they could be a little better. And we have some dysfunction here, especially at L4, L5.
Okay.
Yeah. So that's the
Left
worst
side.
part. Let's try on the other side.
Hopefully
Yeah,
everybody's
L4,
starting to incorporate skid rolling.
L5. Okay. So S1, 2 on this side. So it's pretty into S2. So it's a little stiff there. So it could definitely be, the whole area could be less stiff. Yeah. So that we could take a look at that first and see if we might be able to make that a little bit better. And that could take away a lot of the reason that the trigger point might be activated.
Yeah.
So we'll look at that first, okay?
You guys are doing that,
Okay.
right? You're doing the
Now,
finger
how are you
myography?
doing with your shoe inserts? Tell us about how you're doing with that.
Great. I have a heel lift.
And nice heel lift too.
And shoe inserts that
Okay.
you gave me.
All right, let's look at her symmetry too.
Okay.
So we're kind of expecting her to be pretty symmetrical, and she is. Look at, she's
Yeah.
like really
You feel
stable.
that
See that?
stable? Uh-huh.
It's just like she doesn't wobble.
Great.
And let's look here, and
And
so-
that's with heel lifts, huh?
yeah,
Okay.
Yeah.
I'm sorry. With
she has
toe
a heel
lifts.
lift and first metatarsal.
Oh, she has
Yeah.
a heel lift and first
Yeah.
metatarsal. Great.
And so here she's even too. Let's take a look at her head.
Good, good, good.
Okay, so her posture is pretty good, especially
Okay.
when she wasn't looking down. Yeah, pretty good.
Yeah.
Okay, so we've got a lot of things accomplished pretty good, but we have a few things to correct.
Yeah,
See.
I was calling the skin rolling finger myography. Finger myography.
Wow.
Someone asked, what was that? No, that's the
Finger-
skin rolling. Hopefully you're doing that.
Finger myography.
When you're rolling the skin, you are measuring. They're just, they sell $3,000 machines. I know because I bought one that measures
That's it.
the conduction activity of the muscles along the spine.
Right. But
It's
we're
an EMG.
But we're doing it.
But if you
what's
roll
nice-
the skin, it tells you the same
But
information.
the thing is what's nice about this is as soon as you start treating it,
Yeah.
then you could treat it, and then you could roll it again, and then treat it and roll again, treat it, roll again. They could see whether or not you corrected it.
I always say that this right here is high tech.
This is the high tech.
This is the high tech. The machines
Right
are
here.
low tech.
Okay, so let's take a look at you laying on your tummy, and I think I have a hot water bottle to put under your tummy, which is nice. But
Do you want the big one or the little one?
I found a bottle. Here's a nice one. Here we go. Put it right here.
Oh, we're gonna look at the
Spinal
nerve roots
roots.
first. Okay.
Yes,
yeah.
yes.
Neat.
Okay, I'm gonna give you a face curl in 1 second.
Now that's the chiropractic model. The
Well-
chiropractic model would say all disease originates from the spinal nerve roots.
I know. This is why we create myopractors.
The chiropractors treat both the nerves and the muscles they go to.
That's it. That's
Yeah.
it. Yeah. So you can see there's a slight curve a little here to the right
Yep,
there. So
yep.
I'd like to make that look less curvy.
Uh-huh.
If I remember her history, she had wasn't it true that we had kind of a pretty good curve on you before, right?
Yes,
Like a kind of a scoliosis, wasn't it?
a little bit, yeah.
Yeah. And then it turned into a big C curve, and today it was pretty straight.
Yeah.
Yeah. So we
Cool.
have just a little teensy bit of a curve right here.
Yeah.
So we're just coming along. We're going to find the spinous process, come just lateral to it, and we're going to press right into that lamina groove towards the spinous process attachment,
Yep.
towards the belly, and towards the transverse process attachments. So
Exactly.
at kind of a diagonal.
Mm-hmm.
So, that's what I'm doing. Oh, I find a good spot there.
And last week we showed how you could treat it on the stretch too by having them bend over the table.
That's a great way, yeah. So what if I have a more time?
Yeah.
Maybe sometimes I might do it like this and then like that. Okay,
And
but
then
what if I was
rotate
in a
it too,
hurry? Yeah, but what if in a hurry? I might put it in the rotation and just treat it standing,
Yeah.
leaning over the table.
Yeah.
Like, forget all this preparatory stuff.
Yeah, exactly. Just get right
Just
into
go
the...
for it.
Yeah.
Okay? But it's more conservative.
Uh-huh.
And it's nice to be more conservative because then it brings everybody in.
Yeah, and if you have the time,
Yes, and if you have the
then it's probably slightly more thorough. But
That's it.
yeah.
That's it.
If you want to wow somebody in a 15-minute demo, go for the big stuff.
Yeah,
Maybe.
you go for this on the stretch.
Yeah, go for the stretch because that's where it's
Okay.
really effective.
Okay, so we're gonna go here, and we're gonna look at the longissimus right next to it, and a little bit of the attachments of the multifidus.
Yeah. And these muscles, they just are so full of nerve input. A problem in the medial thigh could send a signal up to the dorsal horn of the spinal cord, and that could irritate that area and cause tension in these muscles. And likewise, tension in these muscles could irritate the dorsal spinal horn and irritate muscles going to the medial thigh. And also, just compression caused by these muscles could affect the nerves going to the medial thigh. So it's just good to treat the whole circuit. But treat what you find is the main thing.
Well, I'm noticing that it's improving immediately.
Yeah.
So that's good. so here again, refine the spinous process, feel the transverse process. We're going to get right in the middle. We're going to angle towards the spinous, go straight into the belly, angle down inferior towards the attachment on the transverse.
Uh-huh.
And then just hold it and breathe and relax. And that was a little bit painful, you were saying, huh?
Yes.
And then come up slowly. That's usually how you do it.
Yeah, you come up slowly, exactly.
You find the spinous process, you find the transverse, you go into the middle there, into the groove. You touch, you go down slowly, and then as soon as you feel the resistance, you stop.
Yeah.
So as soon as you feel the resistance, you stop there. Now you're going to press towards the spinous processes and the attachments of the multifidus and rotatories.
Yeah.
And then towards and down inferior towards the attachments on the transverse.
Oh, great. That was a great description.
Good.
Yeah.
And she noticed.
And come up slowly. That's a really
And come
great.
up slowly.
Yeah. Really great. Exactly.
Okay, so find again the spinous process, find the transverse. Now we're going to press in. And I find a few taut bands there. You feel some too? She does. She sees some taut bands.
Yeah.
Yeah.
If you're having trouble getting deep enough on your clients or patients, then you might be pushing in too fast, not doing the touch first and then go in. You might be ignoring the resistance point and going beyond it, which causes them to tense and resist.
Yeah, it could
Or you might be
happen.
just coming up too fast.
Yeah, all those
Yeah,
things.
all
could
those
be.
things, yeah.
Then also, I did notice that it was worse when she was standing. So there might be other things related to standing.
Yep.
That could be important.
Yeah.
So, and other underlying perpetuating factors might be some of the front muscles might be pulling her forward. If she maybe was sitting a lot, right?
I should have.
So some of the front muscles might get formed in the seated position, and then they might want to be pulling her forward, and that could be causing part of the trouble here. So
I just got an email. Somebody else stole our word, setosis.
they did.
Yeah, we've been using setosis since last year, and then I just saw it in an article.
Well, what
Somebody else
do
used the
you
word
say
setosis.
about
I
that?
don't know.
We have to use it more.
But we've got Olympic sitting.
Olympic sitting.
They don't have that,
Yeah.
right?
That's
yes.
right.
Well,
that's right.
remember, the muscles that go from one spinal segment to the next, in that area, they go inferior and lateral. So she's pressing up and toward the spinous, and down and out toward the,
Very good. So it looks
lateral
really
spinous
good.
process.
So we did pretty good. Let's take a look at you coming up onto your hands and knees.
They go like this. That's why she's treating
Yes,
it like
that's
that.
right. That's
They're
right.
at
They
that
go like
angle.
this. Yep, that's right. Just like that. Yep. Okay, can I have you come up on your hands and knees, and let's do a cat back and an old horse. So arch your back up like an angry cat. Let's look at your shape here. So you see it's a little flat right here, and slouch it down like
She's
an
not
old
angry
horse.
enough. You got to get angrier.
Okay, and let's go up like an angry cat. So it's a little tighter on this side here.
Because you're seeing that, yeah.
Yeah. Okay, so we'll probably have to look at that.
And you're saying that could be abdominals too, or
well,
so as
I'm
keeping
saying
it flat?
especially when she was standing up and we didn't have the full the full skin rolling. It was better laying down. Yeah. Okay, so let's take a look at you sideways. So we're going to move our body support system here, and we'll put this like that. And we're going to have her lay sideways and face with your shoulder towards this way. And put your shoulder right there. And I might have a nice neck pillow.
Hopefully you guys are beginning to use this position. Sharon teaches this position all the time. It's phenomenal.
There.
The neck rolled there, the shoulder in between the two body support cushions. You can
This is
get
the way
almost
we like it.
every muscle in this position.
Yes. Okay, so here we're going to take a look at the adductor magnus. Well, the first muscle was the pectineus.
Yeah, oh yeah, that's true.
So maybe we should do the pectineus
Okay,
first.
let's do it, yeah.
Yeah, maybe we should do that first.
Okay.
But I got her in this position.
Yeah.
So we'll do adductor and I'll get a little pectineus in two different positions.
Remember, no tricky referred pains this week. It'll hurt in the medial thigh and maybe
No,
in the.
let's do pectineus first. Because pectineus is the most likely one.
Oh yeah, it's most likely.
All right, so we're gonna have you lay on your back. Okay, so we'll do the most likely first. Okay, go ahead and lay on your back. So I'd like to see the pectineus and range of motion.
Okay.
So here it's attaching. I'm feeling. Oh, it doesn't want to work exactly right. She can
It
feel
doesn't want to shorten, huh?
No, it won't shorten. No, it hates that.
Oh boy.
It doesn't like that. Yeah, it hates that. It doesn't like it at all. So here's our first muscle. Here's our pectineus. And here's the pain it causes.
Yeah. And she's checking
It's
for
right here.
shortening.
Yeah.
Oh boy.
It doesn't like that.
No.
Okay. So we're going to treat the little pectineus, and then see what we can do to make it work a little better. Okay. So here we're going to get right on the ramus here, and we're going to press on it, and then we go towards. So right on its attachment onto the ramus, on the pelvis there. So we looked at L2 and L3 and L4.
Yeah. You're a great book stand.
My new career.
So tell us about your careers that you've had.
My careers?
Yeah, things that you've had. Did you sit a lot in different careers?
Oh, so I was desk bound for 33 years.
Desk
Bound for 33 years. So that's pretty good. You're doing pretty good for being desk bound for 33 years.
Yeah.
8 to 9 hours a day.
Yeah.
8 to
Except
9.
for the lunch hour, right?
mhm.
But sometimes I would eat at the desk too.
Oh yeah.
So, yeah, occasional bathroom break, but that's about it.
Yeah.
Wow.
2 computers, one here, one here.
Oh my gosh.
Wow.
So I think that has something to do with being crooked. Because I did that
Wow,
for 33
that might have
years.
done it. Yeah. Wow. Incredible. Then you're spending less time doing that kind of thing nowadays.
Yes.
Oh, Sharon, we should tell them the story. Trader Joe's used to have all of their checkout counters facing the same way, so that all of the people would rotate from right to left. So they would grab the groceries and put them on the,
Like this, they go like
in the
this.
bags,
They go
from
like
the
this.
cart to the bags,
The bag,
over and
like
over and
that,
over.
yeah.
And so we went and we did a scan of EMGs on all their employees at a couple locations, and they all had the same back problem. It was showing increased muscle tension in the QL on the side that they were turning towards.
So they were doing like the skin rolling test. He did the skin rolling test on them with the machine.
Yeah.
And that proved that all of them had the same trouble from turning the same way over and over again.
Yeah, the skin rolling is actually better, but the printouts that
Well, you
show
get
colors,
printouts.
you
No,
give it to
color
them.
printouts.
Yeah, color printouts are help with compliance. It's a $3,000 compliance machine, but
It's good.
yeah, why not?
That's good.
And we got them to change. Because everybody's having back problems.
So
now they have equal numbers of left turning
so when
checkouts and
see
right
a-
turning checkouts.
Yeah, they go both ways.
And they rotate people.
Uh-huh.
No one's allowed on left turning for too long or right turning for too long.
Yeah, isn't that great?
That's very sensitive.
Yeah.
That's great that they changed it. It's great that we thought of it.
Yeah.
Mhm. You went in there and he examined them. That
And
was
it's
good.
great that they are such a good company that they really made that difference, because that's a lot of work to change
That was in
out.
Glenview.
Yeah, in Glenview.
Yeah, it was when you had your Glenview office.
Yeah, northern suburb of Chicago. Yeah, they really did it. It's great. Plus it costs them money because we got all those patients. They all came in for treatments.
Well, maybe that was their plan.
Yeah.
They wanted them to come in for treatment.
Yeah, well, that's good.
They
Well,
wanted them to be healthy.
you know what? I used to say that.
Okay, push your leg so straight. Push your leg outward and then relax. Relax, more relax. Okay, good.
Any problem a patient has is a window of opportunity to help
push.
them.
Push. Mhm. Yeah, so it's a telling us what to do next.
Yeah,
And
it gets
relax.
them into your office, which is great. Then you can begin to help them. Otherwise, they don't come in. So it's a window of opportunity. It's a good thing.
Yeah. Oh.
Anybody who comes into your office, you should feel that their quality of life in every area improves. So
You
it's
feel
better
it's
they came in than if they didn't.
Yeah. Okay, so it's working better. So
Yeah.
right there, so it worked better. So I'm just going to go ahead and treat the other pectineus.
Okay, good.
So we're going to take a look at it here. It's attachment, and then also here as it goes over here to the femur.
Uh-huh.
Okay. We're going to take a look at it here, and we want to take a look at it as it's attaching. Okay, so let's go ahead and just have you lift your leg up just a little bit right there. There it's right there. You could feel it doing that job.
Uh-huh, okay. Yeah, so as I was saying, it's a wonderful thing. However they make it into your office, their whole quality of life is going to change and improve for the better. So, don't be sad when someone has a problem, because it gives you a chance to make all sorts of wonderful changes in their life. So.
Well, I sort of have a commitment to thinking about everybody who's coming in as someone who I'll be working with to help them with different problems that come up their whole life.
Yeah.
So I'm there to help them for the next thing that comes up.
Yeah. And you're finding things before they become problems.
That's
too,
right. So another way to work on it is see if we can't pass all the range of motion tests before you get the problems, and then you don't get the problems.
Yeah, and
That's another way.
And as we wrote in our article, you get better brain health,
Mhm.
less depression. There's all sorts of great things. There's so much
Well, if
benefit
you
from
keep
body
moving.
work.
If you can keep moving.
Yeah.
I'm going to check the range of motion on this now.
Okay.
so press down and out, and relax, and press down and out, and relax, and down and out, and relax. Good. Great, so it's working pretty good. Okay, so what's the next most likely one?
Ooh,
The glute-
vastus medialis? No?
It was the next most likely one. Okay, the next
don't
most
know.
likely
Is it-
one
or
is vastus medialis.
Yeah, vastus medialis.
So we're going to do that one next. So the vastus medialis here. So the vastus medialis here. So we're going to do that one next. So let's take a look at the range, and it gives us this really awful medial knee pain. And today we're more concerned with the thigh pain
Yeah.
because it causes medial thigh pain. But you don't have medial thigh pain, right?
That hurts.
Oh,
Yeah.
yeah.
Yeah,
Is
Okay.
that the medial thigh?
Yeah, that is the medial thigh.
Lower medial thigh, upper medial knee. Yeah, it's
No, she's got medial thigh only on this one.
only in that one. Oh.
On this one?
It's on the other
It's
one.
on the
Both
other
of them,
too?
both.
Oh,
So
okay. all
you
right.
got medial thigh pain here and
Yes.
medial thigh pain here.
Yes,
Oh,
I
Yeah.
do.
All right.
And it's weak too, and it
The adductors are very
almost
weak?
passed the range of motion test.
And it, yeah, yeah.
It was almost passing the range of motion
Yeah,
test.
almost.
Yeah, so it's doing pretty good on the range of motion test, but it was weak.
Yeah.
Yeah, so we had a little weakness. Okay, so we're going to treat so this muscle here is going to attach right here, and it's going to come in here and attach all the way onto the patella, and then here onto the patella tendon. So we want to see, does the patella go this way? No, it doesn't.
Doesn't like to go lateral.
It won't go this way. So it won't go laterally. So that'd be this muscle pulling it. See here?
Yeah.
So this muscle will be pulling that, and causing medial knee pain and thigh pain right here. Okay? So let's treat that one and see what happens. Okay?
So this does cross two joints because it's coming from the rami, right?
Yes.
Rather than
Let's
the,
see.
the adductors
Well,
only.
But I don't have
Well,
any-
it doesn't cross. Okay, so this one. See, this is the one they consider crossing two joints because it goes up here,
Okay.
and because this is still the femur, but it crosses one joint.
Oh, okay. So it's attaching at the upper thigh.
Yeah. So it's crossing.
upper femur. Oh,
Yeah,
okay.
upper
I thought
femur.
it was. Okay, I
Yeah,
thought it
right
attached on the femur. Okay.
Yeah.
Great. Good.
So
Just one joint.
one joint here.
Great.
So we're going to take a look at it right here. So first we touch. So we're going to we know where it attaches here,
Uh-huh.
just below the lower trochanter, it's lesser, and then we're going to get. So we're feeling. Oh, I feel a little taut band right there. Okay, so I know I'm at a little taut band.
Okay.
So I'm going to press down onto it there like that, and then so when I get to a certain amount of resistance, then I just stop. Oh, how's that feel?
Right.
Good. And then we're going to come up slowly. Oh, I found the spot. Okay, so I found a taut band there, so I'm not pressing down as deeply.
Do top bands sometimes not hurt?
They
treat it?
sometimes don't hurt at all.
Oh, yeah.
Because sometimes I'll push out all the painful chemicals first.
Uh-huh.
Like we could use an ultrasound machine
Uh-huh.
or the well wave.
Oh, yeah.
And a lot of times, or use a lot of light massage with
Uh-huh.
heat. And we might push out all the painful chemicals first, and then it won't hurt when you press into it. Yes.
But you still have to treat the...
But often it could still not pass the range of motion test because we still need to go and micro stretch it.
Uh-huh.
Yeah.
Cool.
Mm-hmm. It's a little looser now. Notice? Yeah. Is it less painful?
Mm-hmm.
Yeah. So it's getting a little less painful. So here, I'm just going to come down so I'm right on it. I can feel it right there. So you can feel the taut bands right there. A lot of times I might change to my other elbow, just not to use the same elbow all the time. You know, just do something different.
That's me.
That one. So where do you feel the pain with that one?
It's
Around where I am?
Yeah.
Yeah, around where we are.
Now, sometimes we mention nutrition. We talk about nutrition.
Well,
so-
it's nice if you would talk about it.
I might just say one thing about
Well, go ahead.
Dr. George Goodhart was a real brilliant man. One of those few people that has that, remembers everything he's ever seen. He could tell you the page and what paragraph on what book, it said something when he was in, grade school. A real genius, and he devised a system of nutritional correlations to problems in the body. And this one, there are so many, and it's hard to find any sort of scientific proof or reason for this, but the clinical evidence sure proves really effective. All of the thigh muscles, all the ones that are around the hip and down to the knee, all of them seem to be responsive to vitamin E. A person with vitamin E deficiency, and remember, vitamin E and vitamin C work together. So vitamin C is the antioxidant, but vitamin E recharges it. Without vitamin E, vitamin C can't do very much. So Dr. George Goodhart found that any kind of recurrent problems in any of the hip muscles, that's all the glutes, all the abductors, all the adductors, all the quads, and the hamstrings, all of them, and the QLs too. So the QLs down through to the knee, they all responded to vitamin E. And some people would have just pain throughout that entire region, and until they got their vitamin E levels up, it didn't go away. So, that's more than what we teach in this course. But you know what? I thought I'd throw it out there. Some of you might be doing nutrition. We've got people that do body work and nutrition. So,
Well, it's so important.
Yeah.
So I put it in the book. The most thing that we found that people had the difference who comes into trigger point therapy clinics is everybody in the country has low D.
Yeah.
The ones who come in with pain often have low D.
Yeah.
So that would be some of the other things that we like to look for is, do you have adequate amounts of vitamin C? Do you have adequate amounts of iron stores?
Yeah.
Thyroid.
Yeah.
So those are all important.
Yeah.
Yeah. I skipped a couple.
Yeah, there are a couple. I recently came off of, I had a surgery, and then I was on some pain medicine for a while, and I recently came off of that, and I found that I was having lots of aching in my low back, hips, and knees, and I was doing the work, but it just seemed to be such a strange, sudden onset for me to have pain when I shouldn't have had pain in those areas, and I didn't before. And sure enough, it took me a couple months of dealing with the pain before I remembered vitamin E, and I took it, and actually it did absolutely nothing. And I went back to the store and tried a second variety because it was very cheap, weird tasting. I bit into it, and it was just like watery and didn't taste like vitamin E normally tastes. It wasn't sticky. Yeah, it was a cheap brand. It was, I bought it on sale at Walgreens. So I went back and I got like a Nature's. No. So I got Nature's Made, and then it was stickier and had more of the typical vitamin E flavor and consistency. And I'm telling you, within a couple of days, all of it was gone.
Well, it was good that you tried that.
Yeah.
How much did you take?
I took I took 8 a day for about 3 days. But for long dosage of vitamin E is no more than 800 IUs, which is usually 2 of those gel caps
So
a day.
her kneecap is moving this way, but not enough.
Uh-huh.
But we'll treat the adductors to see if that affects it a little bit.
Oh yeah.
But now it's moving, so it's not as stuck as it had been. So we'll take a look at the other side. Let's have you come over and check her knee. So let's see if you notice how much it. So this is the muscle here that attaches here, and then comes over and attaches onto the kneecap. So pull the kneecap that way and see how much it goes that way. See how much goes towards me.
Oh,
Well, it goes that way, but won't go this way.
Yeah, it gets
See?
stuck going that way.
Yeah, now you try it,
Yeah.
Kirk. And see how
Oh yeah.
see how it doesn't want to go outward.
Not
So
hard at all.
this muscle here is holding it that way. And what if it held it that way a long time? And what if she loved to walk a lot? And then she walked a lot. It might rub on the inside more than the outside, or might rub in a certain spot a lot because of that. So it's nice to get the kneecap working really good. Okay, again, we're going to come over here to the lesser throat cancer, and we're going to go ahead and treat the gluteus. I mean the.
Vastus medialis?
That's it. The vastus medialis. That's what we're doing.
Thinking from the neurological perspective.
So, and also we could push the kneecap that way while we're doing it.
Oh, yeah.
Good stretch.
From the neurology perspective, we found that the vastus medialis was strong, but what was weak? The adductors. So can you imagine that maybe weak adductors over a long period of time causes the vastus medialis to take over some of the adductor function, and therefore making it tight and pulling and
So I like to always fix all the dysfunctions.
Yeah.
Because
The weak and the strong.
Yes, everything.
Yeah.
Make everything work, full
Yep.
function. Yep. Because then you might really make you. But if you do that, then you're going to have them all working together.
Yeah. This is deep philosophy here, but no muscle is an island, folks. Think about that.
Hillary, get behind us.
Yeah, they all have synergists and antagonists. When a synergist is weak, then it has to work harder. When the antagonist is weak, it neurologically overcontracts.
Okay, so here it's starting to go
And it
that
looks
way
a little
more.
bit
Yeah.
Oh, yeah.
Mhm. And so then I like to look at a little bit this ligaments and tendons right here, and the fascia that the vastus medialis is attaching onto.
I seem to be
So we're
full
kind
of,
of get it nice and moving. That's good.
yeah.
Okay, so we're gonna check.
I seem to be full of extra advice today, but from a patient management perspective, if something responds to care, even as you're treating it, if it responds quickly, that indicates probably shorter duration of treatment for that area.
It does. It does means that probably she's going to get better really fast.
Yeah, but what if it barely improves
Well,
at all?
Well, it doesn't mean that it isn't good, but it could mean that it's going to take longer.
Correct.
Yeah. What if it takes 4 months of treating it every day?
Yeah.
That still is great because
Sure
you'll
is.
fix it still.
Yeah.
Still great. Yeah.
So you can always tell your patients about what you noticed, in terms of the rate of recovery. This could be more of a chronic condition or more of an acute condition.
Okay, now the gracilis is the next one.
Yeah, gracilis,
Okay, so
good.
let's do the gracilis. So let's give us the go ahead.
Should we do
Yeah.
gracilis
The pillow,
before
big
break,
pillow.
or we could do it after break too?
Oh, it's a break time.
It's about
yeah,
break
break
time.
time.
Should we give them?
Break time.
Yeah.
Okay.
All right, let's give them break time. We get break. Yeah.
It's break time.
One more thing I wanted to ask you, Sharon.
Yes.
If it's responding quickly, do you sometimes find that means it's not the primary problem, or does it? If something responds real quickly, would you be tending to think that something else is the primary problem?
Yeah, something else is probably a lot worse.
Yeah.
But
If there's
but-
a lot of pain and something
Yeah.
responds real quickly, it might mean something else is primary.
it could be.
It could be,
Yeah.
sometimes. All right, I was curious what you thought about that. All right, guys, so when the long hand gets to one notch before the 9, so 44, 744, way back at 744.
Okay, so just go sit up and move around. We're gonna have a little break. Okay. We can see.
Is that painful for you?
Yeah.
Yeah.
But are there things I could do myself at home to?
We're gonna do self-care.
Okay, some self-care
Okay, so
later.
self-care.
Okay, 'cause it looks like a lot of those things I could never do on myself.
With the tools.
Well, we work on how to do it.
Okay.
So we try to figure out how to do that.
Yeah, we'll get you.
She's tall, she can jump down and see her.
My new career as a model.
Ah, yeah.
Oh, little guy.
Oh, the little guy's here.
Hi. Hi. We just got some food, so I figured I would. Can we give you a little bit if you were to maybe? Look in the car.
Mini me.
Mini.
That's pretty decent.
It's a mini.
Want to say hi to everybody? He's going to pretend to be shy, but he's actually flirting. He'll blow you kisses.
Tell us
and
his
say
name
hi.
again.
Toulam, T-O-U-L-A-M.
Hi, Tula.
Irish. He was born on St. Patty's Day.
I do love.
I do know.
Okay.
That's all right.
Have a kiss here for you?
Who are all these people I've never seen before? All these big people.
I've seen you once or twice before.
I didn't even recognize Stephanie.
Hey, you're Sharon.
That's right.
Where's your
Sharon, it's
Sharon?
very early.
Yeah.
Almost the beginning of your life, pretty much, you've seen Sharon.
Yeah.
You've even worked on you a little bit.
Oh yeah, look at that.
Hi. Give me 5?
Go fives?
Can you give me 5?
No, he doesn't. Huh?
Give me 2?
Hey, sure, give you 5. Give me 5?
You did it? Give me 5?
He's not one to be
Not today.
influenced. He
Not
does it
today.
in his own time. Right?
He's looking.
He's absolutely brilliant. He already speaks and he does sign language. And his sentences are just so, it's very complex sentences. He'll see Daddy coming to the car at the end of work and he'll wave and then he'll, I love you, and blow kisses, and then have it food. Like, come on.
You want food?
Come on here, get some food.
I want some food. All right, let's get some food here.
What was the one he learned? So, ouch.
Ouchie.
Yeah,
Oh, so
something
funny.
hurts. They'll go,
And we were swinging, and I was telling him like, this is ouchie. I forgot why. And then once we got off the swings, there was this little like clear, I don't know, toy, right, with different clear sections. And I was on the other side, and then I barely see him, and he goes, ouch. And he bangs his head like this, and then he claps. It's like, see, Mom, I know it.
ouch, right? This, boom. So what'd you get me to eat, huh?
I just got a little,
Look, he's waving. Wave goodbye.
Bye-bye. See you next time.
Bye. Bye, Jordan. Oh, he's
Oh,
blowing kisses. He's blowing
thank
kisses.
you. All right. We got that.
Can you do the thing where you tell everybody to come?
But remember, it was just sent an email.
Yeah, we're gonna do that again. We're gonna do the amazing knee pain relief program.
Yeah.
That's what we're gonna do. Check. You wanna check it? Go ahead. It's emergency.
What's that? I used to have kind of sensitivity to kneeling. I don't think it's quite as bad as I found Aiden about 3 years ago. He swelled up real big. A couple months. A lot of fluid.
Okay. So,
Like a chip something maybe. Maybe like a microfracture or something. So, I was walking across an overpass at night in the dark, and there was a big thing I didn't see like that. It pulled me back really hard.
How long ago?
A year, 2 years ago.
I flew during one winter out of a store, and we slipped. They had like a sort of a sloping, I flew out into this traffic, and I just flew like this out of the traffic, landed, and
Have some
icy.
delicious
There was
muffin
wind
left
everywhere,
over.
wind everywhere.
Raspberry.
And then flew and icy and fell on my knees. and it was hard to recover from, but I totally recovered from it completely. But it was very hard. I think it was the fact that I flew and landed on the knees on ice. Yeah.
I had bloody knees and bloody elbows.
Yeah, elbows. I was all bloody. Yeah. So it's like it's hard on us when we do it that way. Yeah. Oh man. Well,
Sharon,
sometimes when you fall
I
down-
have some delicious raspberry muffin left over if you're hungry. Yes, I do. For whoever wants a little bite.
Okay, well,
Hi, Guy.
Where would you like it?
In the little room next door.
So I have to nail my
Okay.
knee pads.
Thank you.
No
I
problem.
have to do some work around the house or something. I use knee pads. But I can do a little bit without them.
I was working on my knees yesterday on the hard floor, and it felt really good. Then her father, so I know I have enough range of motion of the quads, so the kneecap is rotating far enough under that I don't feel anything. Yeah. So if the quads are in good enough shape, then you're not going to have any trouble. So why don't you have you guys while I treat some
Get some
for
food.
her, let's have you treat some of the stuff on you. Okay.
Yeah.
So you've been heating, that's good.
I've
Let's
been
get-
heating.
You need a jackknapper.
You're there.
There they are. Yeah, you need one.
Sure, no problem.
Okay, is it close?
Or are you gonna work that much?
Her-
Or is she
her.
gonna do self-care too?
I was gonna treat her and you guys are gonna do self-care.
And I'm gonna watch you.
Go on and watch us.
Bring it leverage on me.
There we go, half a minute.
Okay, so I'm gonna have you lay sideways and face that way. And turn all the way sideways.
Massage?
Under your neck.
Is that a nice massage?
Okay, bring this one forward.
He doesn't know what to think of it.
You gonna see me after work?
You can sit on them, that's good. You wanna sit on them?
Oh, you can sit on
Yeah,
this.
you can sit on them. You sort of put it further back so that you kind of like pushes your butt in a certain way.
There we go. You wanna stay and watch the class?
Why not? Everybody else has one.
Bye-bye.
Where's the video? The camera?
Right there.
Are you ready
On the
to
tissue box.
start, doing it?
Yeah. Yeah.
Is this ready to record?
We starting? All right. You know, it's blurry. If you tap the screen, it'll zoom in. Isn't that weird?
There we go. Yeah, all right.
Hey, you learn. I can do it.
Okay.
Give me a break. I get the adductors anyway.
I can treat him. Okay, good. Okay, so we're going to treat a few muscles. We're going to treat the adductor magnus. Okay, that's number 3. Also, we're going to treat the gracilis muscle. So we're going to treat the adductor magnus, which is number 4, the 4th most likely, and the gracilis, which is the 3rd most likely.
The adductors
Okay.
were the ones that tested really poorly on
They
the
did.
strength test and the range of motion.
That's well, not super poorly on the range of
The
motion
one
test.
you did.
Oh yes,
Yours
on
did.
certain one. Yeah,
Yeah,
so
yeah.
they
The
came
lab
out.
one, not so much, but the
Right.
other one they did.
But I had something I wanted to read about the adductor magnus here. It was very, very interesting. Justin, maybe you could read it here. The symptoms.
Is it about the pelvis?
Yeah, right here. If you could read the symptoms. Okay,
Symptoms.
Watch me.
Patients. God, you watch her.
Oh,
So patients with active trigger points in the proximal, that means up near the thigh,
Yep.
okay, they complain of intrapelvic pain.
Right. So these ones right here, right through here,
Mm-hmm.
right here especially, right there.
That may be localized to the vagina or rectum and may be diffuse or described as somewhere deep inside. Some patients' symptoms occur during intercourse. When the trigger point is active, the patient may complain of anterior medial thigh and groin pain. So the referred pain obviously is to those regions, but it also goes up and affects. In fact, we had an article, if you want to look through our archive of muscle news articles, it said, could this muscle be affecting your love life?
That's right.
And that's the adductor magnus, because it really can affect can cause uncomfortable relations.
Right. So here what you do is I find the ischial tuberosity, I touch it, coming down, and I'm going to press up towards the ischial tuberosity.
And the position, oddly enough, that she's lying in right now is the way a patient will sleep commonly when they have pain in the adductor. They'll sleep on the opposite side with the painful side drawn up, just like this. So, it's just another interesting note from Dr.
Travell and Simon.
Yeah.
So I've got some painful tight spots here. Now you remember, can we look at the muscle where it attaches, Justin?
Yeah.
So it's attaching here near the ischial ramus, and then there you go. Justin's going to show us. So here, it's attaching near the ischial tuberosity, and then over here onto the entire femur.
It's big muscle, huh?
Yep.
Big muscle.
So there she has a painful spot.
And these attachment points are really often so sore. Yeah. Here, watch if you tap this. Go over that again. Watch if you just tap this deep. Then it'll zoom in.
Oh,
See?
yeah, that's
Right?
much clearer.
Yeah. Yeah, I find they have to do it quite frequently. Whenever I switch pictures or something. Isn't that weird?
Yeah.
And we're coming down to where it attaches onto the lower femur.
I find that the inner thigh is so sensitive. It's one of those things that people have an aversion to treating themselves. They always have to get used to pushing on them because it can be so tender.
It can be, and it can be so painful. Some of the spots I've treated myself sometimes is so painful. I can't believe how
You can't
painful it
believe
is.
it. Yeah.
It's just so painful. But I know it's going to work. You know, if I do it. So
Well, and whenever I feel that kind of pain, I know that nerve is sending, it's like sending a war cry into my nervous system. I don't want that. You know, even if I'm standing and I don't feel it, if I push on it and it hurts, that means that it's sending that war cry up to my nervous system. It's creating some kind of
it's
problem.
creating-
Yeah.
So if we had that going on all over the body, we might have a super sensitive spinal segments happening everywhere. Then you have central sensitization, and then you get like oversensitive. Yeah.
Yeah.
So here we're going to take a look at the gracilis. So the gracilis comes a little bit more anterior there, and you can sort of feel it. I can feel I'm going over it right there. Then it attaches over here on the tibia, and it crosses two joints. Then, yeah.
And when you get irritation down here, what do they say? What do they call that?
That's tendonitis of the pons anserinus.
Yeah, or bursitis. Or, it's more tendonitis, right?
Well, it is tendonitis, but they might call it bursitis. It could be called bursitis.
I just know that they call it all sorts of
All
things.
kinds of things, and
Yeah.
it really is really just short muscles. The three longest muscles of the body, the sartorius, the gracilis, and the semitendon, the hamstring. Those three muscles are the longest ones of the body, attached there. And if they pull hard, they could be 3 or 4 inches short. They pull hard, they can hurt like the dickens.
Of course. Why wouldn't it hurt from being pulled on all the time? You know, because what would they do normally with
Then they do
tendonitis?
injection there. They
or,
do,
or some ultrasound, which
but they
could
use,
help,
ultrasound would help. But if you just do it at the attachment, it may be not going to help because you need to make the whole muscle longer.
you're not solving the problem.
And the other thing is if you're going to do a treatment just at the attachment,
Yeah.
you could still be having the referred pain.
Of course. Yeah.
So we're a little bit more forward, and I can feel. So when I come down, I'm right on it, and I feel. Oh, I come right to there, and I can feel the resistance, and that's the sort of feels painful, right?
Mhm.
Yeah. So I'm right on it, and I can feel the resistance right there. The pectineus, the gracilis, and the adductors all work together to do the adducting.
Yeah, there's like 5 adductors, really.
Right. That's a lot of adductors.
Sharon and I aren't meaning to put down other professions. What we've noticed is there's a sort of an undervaluing of the body worker for his or her work, and so we are always trying to counteract that.
Elevating.
We're trying to elevate the sense of value that the body worker has for the work they do, because it's possibly the most important thing in medicine to be doing is body work. It increases your own intelligence. It allows you to start to realize that your hands and touch is an instrument, and so when you're using it on yourself, you're getting your own intelligence and using it on others also, and they're all becoming more aware of their bodies too, and that awareness increases their mind openness. It shows them that they don't have to suffer, that they have skills to treat their own situations, and it can change their whole perspective on life. So Sharon gets rid of most conditions that come in the office, and that's in the process the patient learns a lot, and Sharon has a great time doing it. So you should really be valuing yourselves as one of the highest and most important art forms in the medical profession. So that's why we say it. We don't mean to put anybody else down. We're trying to boost you up.
So I'm checking the adductor, see how the adductors are adducting. So I'm checking to see, are they effortlessly adducting? And I'm seeing what won't adduct. Like there.
Oh yeah.
On the spot, I could feel a spot wasn't adducting. So this is the attachment there near the ischial tuberosity, and there's quite a few trigger points. If we want to look at the book, there's quite a few trigger points. If you look at the trigger points right there, right where it attaches. So let's go look at the attachments there. Find the one where the referred pain is. Maybe one more page and forward. There, I think. Yeah, it's right there.
Lots of trigger points right up here.
Yeah, up high.
Right up in there.
Right there.
That's what I was telling you, right at the attachment point.
Right there.
And those are the ones likely to refer up into the pelvis.
And cause trouble.
Yeah.
So it could cause incontinence. It could cause
Oh, that's right, incontinence.
deep achy pain. It could cause. The way people describe it is it's like an explosion in the pelvis. Sometimes it feels like a really bad pain.
Was this the headache in the pelvis muscle?
Yes. Well, this is one of the major ones with headache in the pelvis. Yeah. Better. It's coming along. Okay, so we did the gracilis and the adductor and the pectineus here, and they're moving pretty good now. What did you think of the last part there? It seemed a little bit less painful.
Yes.
So it seemed more painful at first,
Mm-hmm.
and this would be typical. That frequently, after we push out some of the painful chemicals and move it around, that we push out some of the painful chemicals and encourage the movement, and do the micro stretching, then it begins to feel like it can work again. So let's do one more muscle, and then let's do the self-care on the other one. Okay. So let's do the sartorius on the same one. So let's go ahead and lay on your back. And one thing we could do is we could put a little bit of heat on the muscles before we treat them, and that's kind of nice. We could put a little bit of heat on them. That's always good.
So the positions where you were able to treat, in that side-lying position, you were able to treat how many?
I was doing a really good job, particularly on the adductor magnus.
Okay.
But we could have also done the sartorius, but that wasn't part of our thing today. But we did a little bit of the pectineus in that position. Yeah. We did it, but the more pectineus with her laying on her back.
So on the back for pectineus?
Yeah, we did more. We could have done the sartorius and the pectineus together.
Okay.
And the
So on your back for the pectineus and sartorius, and then the rest of them you could do side lying?
Yeah. Mm-hmm.
Yeah. In the vastus medialis we did also on your back, right?
We did that with her laying on her back, but we could that was a good way. That was a good way.
Okay.
Yeah, because then we could watch the kneecap and everything.
So two main
Okay.
positions then
Mhm,
for this protocol.
Right. Okay, so we're going to take a look at the sartorius. So here it is. It's going to attach here. So you could open the book for us on for that one.
Our last muscle here.
Yeah, so the sartorius is starting here, and then it's coming over and it's attaching here.
Yep, it
So
has
here-
two curves. It curves around,
Comes like
and then
this.
it curves around again.
Comes like that. Yeah.
Yep.
So it's just
The
like
longest
that.
muscle in the body.
It's the longest muscle
It's like
in
a
the body.
belt. It looks exactly like a belt. When you do dissection, it looks exactly like a belt from here all the way up to there.
That'd be number 5.
And it hurts at the buckles.
Yeah, yeah. Number 4. Number 5. There it is. Okay. So there's the sartorius. There. Okay, so let's take a look. Let's start at the attachment up here at the superior
And again,
iliac spine.
No real surprises about the referred pain.
Out.
But this one can affect the, this one can cause that nerve entrapment, that lateral femoral cutaneous nerve, which are the,
Well, it could, this one could compress, so the cutaneous femoral nerve could come out right there. So it could come right out there. This could be pressing on the lateral cutaneous femoral nerve. And then we could have numbness on the side of the outside of the leg here. So here's our sartorius. Here I can feel it right there. So this is
not happy, right?
Not a happy
Especially
camper.
at the origin insertion. You see the
Yeah. So here I'm treating it. So then we get to how you should do it. Have you treat it.
Okay.
There's no surprises with the referred pain on this one. Where the trigger point is generally where this referred pain is.
The pain is right where you're pressing.
See, so if it's up higher, then it's a little higher. If it's in the middle, it's a little in the middle. And if it's lower, then it's toward the knee there. Sartorius, so. No fancy referred pain in this area except for that adductor magnus causing the pelvic issues.
That was sort of fancy.
That's real neat.
Yeah, it's crazy.
Yeah, it's crazy. Yeah.
That's a crazy muscle.
Do you
so
guys
it
see
attaches
how
like on your sit bone?
how this one pulls? When it pulls right to here, it like takes this twist out and makes it straight, and that's how it brings it up in that lap position. It like literally pulls the knee and up and out to make a lap.
But why do they call it sartorius?
You're gonna tell me because I have no idea.
I know.
Why do they call it sartorius? I was gonna make
Because-
something up, but
Okay, so the people that used to do when they used to do sewing, they would come like this and they would use their leg like this to sew. So this would be, they would sew a suit. So it's sartorial splendor, suit splendor.
Oh.
So this would be the way that so this is the sartorius muscle was used to sew, just hand sewing.
Oh, right. So we got the pectineus, we got the fruit muscle and the suit muscle.
Yes,
And it's called the Taylor's muscle.
that's right.
Oh,
the
Taylor's muscle.
Yes,
I
the
did know
The
that.
Taylor's
Yeah,
muscle,
the Taylor's
because
muscle.
that's right, the Taylor's muscle. That's right. That's right. That's right, because the Taylor would use their leg that way.
I'm terrible at trivia.
Oh.
Huge one. Now, what would George Goodhart say about the sartorius and the pectineus?
What do you say about it?
Oh, sartorius and gracilis, I mean. He would say that they're related to the adrenal fatigue.
That he would.
Yeah, and so he would treat the nutritional correlation for him for the
Uh-huh.
gracilis and sartorius would be giving some adrenal support, some good, healthy adrenal desiccated glandular supplement, and that's what he would do.
Okay, let's test the range of motion. See how we did on this one.
Oh yeah, what's the range of motion on this one again?
This one again.
Right, you don't
Would
see
be
this on the charts.
opposite of the.
Oh,
that's a
look
little
at
better.
that. That's a lot better.
That would
Wow.
be like, this is close to where you want it, but it's not perfect. But it's close, it's close. Okay, now bring your ankle inward. More this way, push this way. And relax. Okay. And inward again.
Wow, look at that.
And relax. And inward.
And remember, some
And
range of
relax.
motion is that end
And
feel. It should
Okay,
smoothly
now
go to end
also I
range.
want to feel all the muscle. Now I've got it on the stretch. And I want to see, especially this part on the stretch here, and I want to see if something I treat makes it stretch more.
Okay, she's pushing on each part of the muscle and
And I'm
checking to see which one might
So I'm
cause
putting
an
it on the
additional
stretch.
release.
So I'm looking what makes it release more.
Exactly.
So here, now I'm going to add this part. Okay, there. This part right here. Yeah.
Where was that pain when you felt it?
Right there.
Right where our fingers are?
Push
Wow,
ankle
cool.
in, push in. Yeah. And relax.
So that means that
Push
that
in.
little segment of muscle saying,
In,
no,
in.
you can't do that.
In, push.
And then Sharon shows that, yes, you can.
And push in. Okay, good. So look, oh, nice.
Wow, look at that.
Oh, pretty good. Okay, push towards me. And relax. And push. Good. So I'm doing the opposite. Push in again. And relax. Push in. Good. Okay, that was great. Okay, so
Fantastic.
we did a few interesting muscles. Let's also look at the vastus medialis. Let's look at its range of motion here. Okay, push inward with the ankle and relax. And push inward with the ankle and relax. Okay. And push towards me and relax. And push towards me and relax and push. Good. So I'm trying to get them to pass the range of motion test. Here, she's passing the range of motion test.
Great,
Okay.
yes.
She passed the range of motion test for the sartorius.
Yes, she
Okay?
did.
So that was good. So let's take a look at the range of motion test here. Let's look at the adductor in this position and the pectineus in this position. And push up just a little bit and relax. And push up a little and relax and push and relax and push and
So again,
relax.
she's
Good.
checking which part of the adductor is
And push.
resisting that.
And what part still has taut bands?
Yeah.
And push. Mhm.
So this is really cool to
And push.
incorporate the range of motion test and the treatment together, just as
Push.
she's doing here.
So my goal is to get them to pass the range of motion test and all the fibers, not to have any hard, painful fibers. Good. Okay, so it's looking pretty good. Let's see how we're going with this test here. So now it's looking very
Oh, yeah.
nice.
Very perfect, pretty close to perfect.
Really good. Okay, so let's put a little heat on it. Oh, give it nice and warm. Give it a little warmth now after we did all that. So that was a good pass. That was nice. So you're doing really good with that. What other tests should we do? Let's see.
Well, did you treat this side too?
No,
Or should we
no,
do self-care on
no,
that
she was
side?
going to be doing self-care on that side.
Okay, so I could do the strength test on this side that you
Yes,
treated.
you
If
could.
you wanted.
Yeah, we could do that. We could do that right now. Yeah. So, did we miss any test? I just think.
Oh, the one where you bring it out to the side with your with the leg.
Oh, that one. Yeah.
The
okay. But we did
straight
this one.
leg.
We did this one. Okay. So, let's go ahead. Let's look at that one again. Let's look at our. I come out to the side. So a little bit tight there. Okay. So let's have you press. Yes. Okay. So push up towards the ceiling a little bit, and then relax. Okay. So I'm just gonna look what's causing range of motion dysfunction here. Okay, so
jumpy points.
push down towards the floor, the other way, yeah, and relax. Okay, push down towards the floor and relax, and down towards the floor. Good. Push down towards the floor.
Those jumpy points are in the adductor still?
Yeah, yeah.
Mm-hmm.
Adductor magnus. And push down, push, and relax. Good. Okay, so it's coming pretty good there. That's much better.
Mm-hmm.
So I'm always trying to get you to pass the range of motion test. Yeah. Okay, so that was pretty good. You did very good. You improved like a whole lot.
Will it stay like that?
Well, let's see. Especially if we train you to do it, right?
Right.
Okay. So Justin, you want to do a little bit more
Sure.
with her there?
I'll do a couple
Okay.
of strength tests. Love to.
Great, super.
Okay.
See
So
how
she wasn't. I'll review them anyway. But she wasn't weak in the vastus lateralis. But just to review them for you guys.
But just doing that like
Just
yeah.
like this. Oops, sorry.
Mhm.
Like this. What am I doing? I'm on the wrong side.
Okay.
Sorry. Okay, there you go. Vastus lateralis, you turn the leg out and push up toward the ceiling, and I push down. 1, 2, 3. Okay, good.
Medialis.
Medialis, sorry.
Uh-huh.
Medialis. Got it all turned around. And then for the adductors, this was weak. The foot is straight up and down. I brace this one, and I'm pushing out here. So push into my hand, push in, and then I add 1, 2. So still weak there.
A little bit weak.
Something's still going on with the
Okay.
adductors.
Okay.
The gracilis was strong before. Gracilis, you turn the foot in, Now push down and in at an angle, and I'll push up and out at an angle. Okay? You at 1, 2, 3. Okay. And so gracilis was fine. It was the adductors still, though. And what other muscles do we have? Sartorius?
Yeah.
That's it. Sartorius is the only other one. Okay. Bring it up into the knee, into the lat position. I'm going to pull. You push this way with both the ankle and the knee simultaneously. Push up, and I add 1, 2, 3, 4. Okay. So Sartorius got better.
strong. Yeah.
The adductor's still complaining.
Yep.
You found that with your range of motion test, and I found that with the strength test.
Yeah. We had a little trouble.
So,
Okay, so
what were the nerve roots?
oh, we were looking.
L2 through L4. So here's one way you can.
Oh, he's going to take a look.
This is the way you can do a muscle test quick check just to see. So I'm just going to press around the L2 through L4 range. I'm just stimulating the nerves. This isn't fixing anything yet. I'm just doing a quick test. Now, push this heel toward the other one. Push in. I'm going to add 1, 2. No.
Okay, so
not really much.
Okay, so it doesn't seem like much change. So
you can pinch along the muscle, the body of the muscle,
and then
kind
see.
of
All right,
see
so it's a little
any nerve in there.
test. Yeah.
There's another little test to do.
All right. Okay. Then you're gonna do it. Okay. Okay. So now
push
test
in,
it.
and I add 1, 2, 3. Oh, that's it. Okay.
It's a little stronger.
Yes.
Yeah,
and you could pinch one spot at a time.
Yeah.
And check, and another spot at a time.
Yeah.
And check, and you could find which spot really is causing it to shut off. It means there's a nerve in there saying, I don't want this muscle firing.
Yep.
One nerve is saying this muscle shouldn't fire, and that nerve is wrong. So we'll go back over it, and also probably be most tender that area.
So what we could decide is to treat it till it gets strong.
Absolutely.
Or we could just treat it next time they come in and do it next time. But we're going to be doing either this time or next time or the time after.
Yeah.
You're going to keep treating it till it has full range and it's strong. It's not painful.
How about I pinch? Why don't we just find it out?
Okay.
So push in toward that side. So my pinch only lasts maybe a couple seconds. You know? It'll go right back towards weak. So let me pinch the bottom third of the adductor. Okay. Bottom third of the adductor. And push in. 1, 2, 3. That's it.
That did it.
Okay. If we just wait a few seconds. Yeah, you can get the stimulus gone, right? And let's see if it's weak yet. Push in. Oh yeah.
Okay, so
what if we did the medial?
Try the medial.
Middle third. What if I did the middle third?
Just a little
middle third of that.
Test.
Yeah, little test. I didn't touch the bottom third. I just touched the middle.
Okay, see what's happening.
Push in. Yeah, nothing. No change at all.
So
nothing
lower,
at all.
Lower
it's
so
got to be, right?
So we want to try higher.
Yeah, we'll try the higher adductor region. Pinch
so that's
on
more
here.
That's the brevis and the
yeah. Push in.
longus and the brevis.
Nothing. No change at all.
Okay, so what if we treated that lower part again?
It's that lower part.
Yeah.
And is it still tender a lot in there?
Yes.
Oh, it's very tender. So she could tell you that the nerves are firing. This test tells you nerves are firing. So so with your palpation, I already feel it's still gnarly in there. That's my word, technically gnarly. So it still needs more is all it means.
More.
Right? More.
Okay, so
how about we do self-care?
Yeah.
How about she does the more?
Okay, so we could do more with this now.
Yeah.
Okay, so let's
or whatever you want to do.
Yeah. So let's take a look a little bit. I'll treat it a little bit, and then we're going to start you with the self-care. Okay, let's turn you that way. Okay, let's bring this knee up. So sometimes for sleeping, it's nice to get your shoulder up high enough like this and your neck so your shoulders isn't squished too much. So this is a McKinsey neck roll.
Oh yeah. So that was functional muscle testing.
Okay, so we're going to take a look right here at the both at the adductors all through here.
Yeah, and part of the reason is like just pushing on the area, it's almost like you don't want to push because it hurts so much when it gets so tender.
It does.
But you have to get past that breaking point.
That's it.
It really is. It feels like it's almost going to break, and then it lets go. Just.
It feels like you're tearing it.
Right. It feels like I've actually had it where it feels like the bone is literally going to snap. I can't believe you could possibly endure this much pain, and then it just goes away, like just melts. You know, can I talk about the body buffer for a second? I found this muscle responds really well with the body buffer.
Well, let's see if she likes it.
You like it? Yeah, okay, so we actually have one.
I have some.
This desensitizes really sensitive nerves. Something about the vibration causes the gate effect and stops some of the sensitive.
So heat, cold,
yeah, heat,
vibration.
cold, vibration, yeah.
Yeah. So sometimes we like to check it to see how this works. So start about medium, see how you like it. Have you had the buffer before?
No, it's like doing the floors, right?
Yes.
Yeah, exactly.
So let's see if we can.
Oh, and treating it, you
We're
know,
getting the-
on a stretcher stuff
We're
too,
treating
exactly.
yeah, I like to treat. So we're treating the vastus medialis on the stretch here. And go ahead and press towards me. And do you think it'd be okay if I made it a little higher?
Yeah, I think so. I think a little faster.
Yeah. Oh, the other way. What do you think?
And now it's like the buff in the car.
No, it's the car.
Now the
Gone from the floor to the
car
car.
buffers work a lot faster, and it's a bit too much.
Yeah, and you don't want to use a car buffer.
Well, some people do, and it might work for some people.
Oh, okay. I didn't know.
But it can be too hard, it can be too fast. Okay, let's get up here to the adductor.
Sharon, do you think maybe we need to treat that area on the stretch, that adductor? Or?
Yeah, I just did it a little bit on the stretch. Let's do it again on the stretch.
Yeah.
Let's do it with the buffer on the stretch. So here's the magnus. Okay, let's go ahead and have you lay on your back again.
Oh, this is called a body buffer, but it's any kind of a vibrational tool.
Well, they
changed
call it
it?
Myo Buddy.
Myo Buddy now?
Yeah.
Oh, that's ridiculous.
Okay, so here we're going to treat it a little bit while
Treat
we're
it on the
stretching
stretch,
it.
yeah. Exactly.
Press that down towards the floor. Just go and relax. So how sensitive is it? Medium, okay.
And I wasn't saying this could replace compression or anything. This can relieve some of the sensitivity if it's so tender you're having trouble
Well,
compressing.
it's a stimulating
Yeah.
treatment, and so it can be very good for some people. It might be way too stimulating for others. So it could be really good or not really good depending on the person. Yes.
So how's that?
Should we
How's
test
the
the
medium?
strength?
Yeah, we can test strength. Well, might need to give it a second for that stimulus to wear off a little bit.
Okay. All right.
Yeah.
Okay, so go ahead and press in towards me. One more time. Go ahead and press in towards me. So it's still a little bit weak.
Still giving
Yeah,
away,
a
huh?
little bit weak,
And if
yeah.
what if I were to pinch in this area again, see if you notice something again. Oh,
Okay.
it still feels tight in there, doesn't it?
Yeah.
Yeah.
And press in. It's a little stronger.
And it changes it,
yeah,
doesn't
so
it?
it just needs more.
It
there.
just needs more.
there.
Just needs more.
Yeah. Okay.
How about
so,
self-care?
Yeah, we're gonna do self-care. Self-care. Okay. Okay. Let's have you go ahead and turn to one side, and then go ahead and sit up, and then stand up. Okay. We're gonna do a little stretches for the ones that we just did.
Okay.
Yeah. So for the adductors, we're gonna come like this. We're gonna put our legs apart. We're gonna come down like this and do like a flat back. Like look up with your head, and you're gonna go to one side, and then you're gonna go to the other side, and one side, and
Slalom.
then the other side. Good. And then for your gluteus medius, you're gonna grab your leg and take it out to the side like this.
To the side?
Yeah, a little bit outward. That's for the medius part. Good, good. And then, do it on the other side. And then also, you're walking sideways is good for the adductors. And then walking toes in, toes out, toes in, toes out, toes in. A lot of times you walk, and while I'm walking, I turn one in out, and I get my walking in like that. Okay, so let's go ahead and let's treat our adductors.
She can also
Okay.
cut in line, and people always let her in. She walks like that, then they just say, "Sure, why don't you go first?"
Oh, do you?
That's why Sharon does it in the store.
Okay, all right, so get a tool, and we're going to get your protocol here, and we're going to treat ourselves. Okay, so this is yours. And you can come over and sit down. we could find a good spot for you.
This guy has a leak. Okay. No wonder my pants are wet.
You think I like this chair better?
Oh, maybe, yeah.
Okay, so you look like you like that chair.
Try and find a leak for me, okay? Thank you.
Okay, I need a jackknobber tool.
There were plenty over here a second ago.
Okay, so we're gonna go ahead and we're gonna treat the other leg that I didn't treat.
Mm-hmm.
And, or also this lower, let's treat this lower
Yeah, let's
section.
get that lower section really good.
You find that jackknobber tool.
It was the other side that, yeah.
Yeah, well, they're both.
Yeah, they're
Okay,
both
so-
bad, yeah. It's
So
a-
remember, so the muscle attaches up here near the ischial tuberosity. So we're gonna come all the way up there and press in. And then we're gonna keep coming down and breathing and relaxing. And like I have one helping the other, kind of like that. So here, so it attaches right here. Then we're gonna come in, and now we're looking for a painful spot. So we're gonna press on, looking for a painful spot. And let's come down a little lower. Oh, so then you found a really painful spot. So then you're gonna hold it and breathe and relax. Oh, breathing and relaxing. Okay, let's come down a little bit inferior towards the knee. And we're looking, and it's coming a little more inferior towards the knee. And a little bit more inferior, and then it attaches down here. So right above the bony part right here. Right there on the femur. And let's look around for some more painful spots near that area. And we could test the strength. We could come like this and push our knees together and relax and pull them apart. And we push them together, push, 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 and then pull them apart. Give them a good stretch. And let's push, 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 and then pull them apart and give them a good stretch. So let's take a look at our pectineus, okay? So our pectineus, so it attaches right here on our pelvis, and it comes over here and attaches on our femur. So it's not very long, but it's right there, okay? So let's start on the femur part right here. So again, I have one hand helping the other. So I'm right in the spot where I want to be. And we're going to press right on it like that. And we're breathing and relaxing. So sometimes we start with the self-care first.
Yes,
And sometimes we end with the self-care.
that's right. Sometimes we do the whole protocol.
That's it.
Or sometimes we do one muscle at a time.
That's it. That's how we do it. Sometimes we do different things. So when you find a painful spot, you might hold it for several breaths, 2 breaths or 3. And then as it gets a little less painful, you might press in a little bit more.
Yep.
And you're looking for it to be less and less and less and less painful. And they have more and more and more and more function.
Yeah, yeah. May I add one technique thing from applied kinesiology that they talk about as well? So we talked about remember what we said are at the ends of muscles? Golgi tendon organs, right?
So
yeah, and so you would push, in toward the belly of the muscle to help relieve the tension on those guys.
oh yeah.
But now, in the rest of the muscle, in the belly of the muscle, there's something called spindle cells. Spindle cells are like little springs. They're coiled around like this. And when they are shortened, when a muscle fires, first a signal goes to the spindle cell and causes the spring to go boing, and then that causes, to stretch, boing, and then that causes the muscle to reactively contract. And that's actually how it happens. As the intrafusal fiber shoots first, then the alpha motor neuron actually fires. What if in this area where we were treating, where I kept pinching...
So this is so it's here and then to there. Okay, just right there. Yeah.
What if in this area there was a spindle cell that kept sending the wrong message? Spindle cells that are too compressed, the spring's too short, they will cause it to shut off. So you need to stretch it. So one technique is, in addition to compressing, you can
pull them
spread.
apart. We can pull the fibers
Exactly. You can spread them apart.
apart. Spread the fibers apart. So,
Yes.
So this would be going ahead and pulling the fibers apart
Exactly.
like that. Yeah.
Oh, I see.
Yeah, so that's another technique. And then
Yep.
one technique he was talking about too is at the attachments, pushing them upward
Yes.
or pushing them inward like this. Okay.
Exactly.
So let's see.
So like
So
that.
Yeah, exactly.
like that.
And then like that,
Pulling them
or like
apart.
that.
Yeah.
It doesn't matter
Well,
what direction.
Well, if you knew which direction the muscle fibers were,
Yes.
then you would do it. Yeah, that's the. That's
Since the
the way
muscle
they
going
are.
this way, then you spread them
You go
apart
the-
like this.
But it's not so much that, is you actually are actually pulling the fibers apart like that. Like you press on it and then you pull them apart.
Exactly.
You press on them and then you pull them apart like that.
And this might be one out of
like
every
stuff.
20 or 30 cases, but you know, since it wasn't responding, you can try that. And if you do this and you feel the muscle really loosening up with this technique, then you could say, all right, you know, and then like you say, you could teach them to do it themselves, especially down here. That pulling apart might be really the critical step to getting that. If that spindle cell is shutting off the whole muscle, it's a neurological problem, and you need to spread the fascia like that.
I feel that all the way up in my
You
neck.
feel it? Is it like really activating a lot of things up there? Yeah. So maybe there's a lot going on to this, okay? So where the
They're
just
asking
as
if it's primary in the belly of the muscle.
the spindle cells are in the belly of the muscle. So we're say the belly of the muscle is, you know, anywhere in here, and the insertion points are up all the way here, and that's where the GTOs would be here and along there, and then the spindle cells would be anywhere in the belly. Yeah. So
So that would be the best for origin and insertion. It's more for the belly.
origin insertion would be more for the Golgi tendon organs at the.
So
But would you use the same technique is what they want to know.
In origin insertion, you push up and
That's
in
right.
toward the belly.
Right.
And here you're spreading apart.
Right.
So at the origins, you push in the bellies, you spread apart.
Good.
Okay?
Okay.
To
I
get a
think
weak
that
muscle to
answers
get
the
strong.
question. Good.
Yeah, perfect.
okay, so let's take a look at the pectineus again. So here we're gonna see. So we want to see, does it actually work? So we're gonna let's stretch it. So let's take the pectineus away from us, and let's take the pectineus close to us. And we're gonna our tool right in the pectineus, and we're seeing, is the pectineus working? So, okay, so good. So we're checking that. So here's our adductor, and we're gonna do the same thing with that. Let's get right on there, and then let's adduct it and see if it feels like it's adducting. So you're noticing as the adductor adducting.
Great, cool. That looks good.
Look for some spot that doesn't feel like it's adducting. Okay, now we want to take a look at the sartorius, okay? So remember, it starts over here, so way up here at the top of the pelvis, up right here. And so let's go ahead and remember we had a sensitive spot up there because remember there's a nerve that can come right through the muscle right there. The cutaneous femoral nerve, and that can cause the whole outside of the thigh to be numb.
Yeah.
Okay? So we're doing the compression on there, so we're micro stretching it. And remember, it comes down, 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 and then it comes over here. So right now, we're treating it a little bit on the stretch by having the leg like that.
That's up at the ASIS, right?
Yes,
Yeah,
yes.
Exactly. Same
So
place
the
where the
top-
rectus femoris inserts.
Just above it, yeah.
Just above it. Okay.
Yeah, just above it. Yeah.
Cool.
And then we're going to come down right there. Yep, we're getting a really good stretch. See how you got it, especially if you take the leg a little, the foot a
Oh,
little
I see.
outward.
That's nice. Wow.
You're getting a really good stretch on it while you're pressing on it.
Yeah, wow, very cool.
You're getting a good stretch on it while you're pressing on it. Come here. So we're getting right on it. And we're going to come right down onto it. I'm going to keep coming. And remember, can I come down, 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 and down all the way to where it attaches on the lower leg, the tibia. Now we want to see, does it do its full job? So we want to see, does it come up? And then does it go out? And let's get on different spots of the sartorius. And then we're going to go like this, and then like that, and see if we get on a spot that when we get on it, does it make it easier?
Wow, I have to say, you're looking really good right now as you're doing that. Isn't she looking good?
Very good.
I wonder if we may have just hit this spot because you really
That is
looking like
good.
it looks like smooth, good muscle function. Wow.
Yeah, it does, yes. And keep coming up higher.
I
And
would
then
hesitate to say I could do this that well. Oh, they like this. People are liking this technique.
Uh-huh.
Good, yeah. Wow. That's really good.
And then all the way up to where it attaches.
Hurts but good, yes. Absolutely.
Uh-huh. Okay, good. So we got the pectineus, we got the so we treated the medius here, but let's do it again, the vastus medialis here. Let's go ahead and look at that again. So remember, it's attaching here, and then it's coming down and attaching on the inside of the kneecap. So let's go ahead and let's take a look at that. And we're going to press into it and use 2 hands. And we get one hand help the other hand. And one help the other.
The thing I had said about vitamin E earlier, with vitamin E you'd find probably all those muscles to be weak.
Yeah.
So since she had several muscles that were quite strong, it's probably not that
Probably
nutritional
not
component.
that. Yeah,
Yeah.
not that.
I thought I'd mention that.
Good point.
When you get someone with the vitamin E, it's like a magic bullet for their back and thigh and knee pain. They just, every muscle you test is like jello, and and then they eat some vitamin E and it comes back. But that's that's very advanced work. But I mention it because you never know. It's one of the few silver bullets. If there's a great silver bullet, I'll probably mention it. That's one of them.
Great. Okay, so I think we looked at just about
Yeah.
everything. Yeah.
Do you want to
Yeah.
test that
We're
one
gonna
more
test
time
it.
just
We're
to
gonna test
see
it.
if?
Yeah, to see how good we did. So you did a little treatment on that. Justin did, and you did a little
Yeah.
treatment on it. Okay, great. Let's go ahead and test it again.
One more time.
Let's go ahead and have you lay down one more time.
Do this muscle test first.
Let's see. Okay, so go ahead and you're gonna let's press this this leg towards me. I'm gonna add a little more. Looks like we're not quite strong enough
Okay,
yet.
strong.
Yeah.
Let's see.
Yeah.
Okay, go ahead and push in, and I'm gonna add 1, 2. No, still something there.
Yeah, yeah.
Let's see. It
Oh.
really needs more work there. Okay, let's try this again. Push in, and I add 1, 2, 3. So it's
That's it,
definitely
that's
there.
it, that's it.
This is just it needs a lot of work. It just needs
So,
more work.
well, we want you to work on this.
Yeah,
and
that's
then,
your homework.
And then next time you come in, let's try it again.
Yeah.
let's do it again. Yeah. So
Can I try this side? Because this
Oh, yeah.
side, when
Let's-
you were
let's check-
doing
let's do it. Yeah, let's do it.
they look so good.
yeah, that one looks. Let's check it.
So how about pushing in on this side, and I add 1, 2, 3. Yep, that one
That
we
one,
got.
that was good. That was good. That
So
one,
this one was weak, and
yeah,
now it's
now
good.
it's strong, and we had 2 muscles weak.
This one we just couldn't. We
Yeah.
haven't gotten enough yet.
Yeah.
Wow.
Not quite yet. Yeah.
When she was doing it on this side, the range
Okay.
of motion, it looked so good.
Now it's 8:30. Now remember what's going to happen next week and the
Oh,
week
gosh.
after, right?
You're gonna bring all your friends.
You bring all your friends because we have the amazing knee pain relief program, right? And everyone's gonna learn how to fix their knees.
Yeah. What's the problem with knees? Everybody thinks it's a joint. It's
Right.
not. It's a muscle.
It's mostly muscle dysfunction. As it turns out, it's mostly muscle
There's
dysfunction.
muscles all around it, back, front, side.
Yeah, everywhere,
Yeah.
everywhere. Yeah.
Yeah.
So one person that was told that they had to have their knee totally replaced.
Yeah.
We looked at it, we x-rayed it, we found that it really had good cartilage. We fixed it, and then she wrote us from Greece and said, she's walking up Mount Olympus. So if you have knee pain, or if your friends have knee pain or family, remember, it's very likely could be muscle dysfunction.
Oh yeah.
Okay, so we're going to be doing that next week and the week after. What dates is that? It's the 11th and the 18th, I think. Yeah.
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 7 from today and 7 from that day.
So that what protocols of the next one would be 25, 26, and 28.
8.
Yeah.
And the next one is 27.
And then the following one's 27. So download those and get them ready for that class. Okay.
All right.
We're ready.
Here comes the song. Any pride you have will now be stricken out of you.
Nobody warned me about this part.
Range of motion.
Okay, so hip sides right, left, right, left, right, left, right, left. Toes in, toes out, in, out, right leg, in, out, in, out, in, out, other leg, in, out, double time, in, out, in,
You back again next week.
Thank you, students. Every one of you, it's putting your time in this class. We love you all. Thank you.